the power button. Just close it to the mic. Just press. It's on. It's off.
Okay, sir.
To play music.
Okay, sir.
You have music?
No, sir.
What type of music should we play? Something from YouTube? Like morning exercise?
Background music for exercise. I'm thinking about the music. That. Otherwise,
No, we can close
simple.
it.
We can close the door.
Inside as well?
Who is doing it inside?
Doing sir.
Okay.
Sir, we can. We can.
Or it's already switched on it.
Yeah, just press that.
A good will form. Everybody has done it. You have help. It is.
Well, you turned on me, you bet I felt it. I tried to eat juice, be juice, hope that I melted. But tried to the cry, and I'm trying to get by. With all the good turn around, I'll be giving in my bestest, and nothing gonna stop me but if
You have to store it. You have to have it. We have a
Hello.
Just breath, just the way it is. Settle down. Now slowly bring awareness, ears,
Hello. Check.
do not try to attach any meaning. Try to be completely non-judgmental. Take a deep breath in. Let us start. Counting 3 or deep breath in. Oh, oh. Oh, oh, oh. Om. Feel the vibrations.
Hello, check. Hello. 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1,
Before you hit the skip button, I can get your car insurance quote in just 2 clicks. Tata AIG car insurance. Trusted now? Fantastic now.
1, 2. Release and start closer. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10, 9, 8, 7, 6, 5,
We were running on the edge of something
1, 2, 3,
something beautiful.
4, 5,
Celebrity, smoking mirrors, keep us waiting on a miracle, on a miracle. Say go through the darkest of days, heaven's a heartbreak away. Never let you go, never let me down. Oh, it's been a hell of a ride, driving the edge of a knife. Never let you go, never let me down. Don't you give up, nah, nah, nah. I won't give up, nah, nah, nah. Let me love you, let me love you. Don't you give up, nah, nah, nah. I won't give up, nah, nah, nah. Let me love you, let me love you. हम तेरे बिन बने नहीं सकते, तेरे बिना क्या वजूद मेरा। तुझसे जुदा अगर हो जाएंगे तो खुद से ही हो जाएंगे जुदा। क्योंकि तुम ही हो, अब तुम ही हो जिंदगी, अब तुम ही हो चैन भी, मेरा दर्द भी, मेरी आशिकी, अब तुम ही हो। Don't fall asleep at the wheel, we got a million miles ahead of us, miles ahead of us. All we need is a roof we can hang to know we're gonna die, know we're gonna die. Don't you give up, nah, nah, nah. I won't give up, nah, nah, nah. Let me love you, let me love you. Don't you give up, nah, nah, nah. I won't give up, nah, nah, nah. Let me love you, let me love you. हम तेरे बिन बने नहीं सकते, तेरे बिना क्या वजूद मेरा। तुझसे जुदा अगर हो जाएंगे तो खुद से ही हो जाएंगे जुदा। क्योंकि तुम ही हो, अब तुम ही हो जिंदगी, अब तुम ही हो चैन भी, मेरा दर्द भी, मेरी आशिकी, अब तुम ही हो। Hey, I was doing just fine before I met you. I drink too much and that's an issue, but I'm okay.
Hey, you tell your friends it was nice to meet them, but I hope I never see them again. I know it breaks your heart. Moved to the city in a broke down car. 4 years no calls. Now you're looking pretty in a hotel bar, and I can't stop. No, I can't stop. So baby, pull me closer in the backseat of your Rover that I know you can't afford, like that tattoo on your shoulder. Pull the sheets right off the corner of that mattress that you stole from your room back in Boulder. We ain't never getting older. since the day I met you. I forget just why I left you. I was insane.
Stay and play that Blink-182 song that we beat to death in Tucson. Okay.
I know it breaks your heart. Moved to the city in a broke down car. 4 years no call. Now I'm looking pretty in a hotel bar. And I can't stop. No, I can't stop. So baby, pull me closer in the backseat of your Rover that I know you can't afford. Bite that tattoo on your shoulder. Pull the sheets right off the corner of that mattress that you stole from your roommate back in Boulder. We ain't ever getting older.
कहाँ से आप?
इलाहाबाद से।
क्या नाम बताया था?
अलग अलग पांडे। अवार्ड का तो पता नहीं है, पर सबसे अच्छा टीचर बनना है, एकदम बेस्ट वाला। रिवॉल्यूशन एजुकेशन लाइन में कोई टीचर लाएगा, कंपनी नहीं। हेलो बच्चों, क्या हालचाल? बढ़िया एकदम। Amazon शॉपिंग ऐप पर मिनी टीवी का बटन दबाइए और देखिए हमारी नई सीरीज फिजिक्स वाला, बिल्कुल फ्री।
bigger an instrument is, the lower the sound, and the smaller.
Hi, I'm Sam Coles. I'm the principal fluting family. The flute is a member of the woodwind family, and it differs from the other woodwind instruments in that it doesn't have a reed, and you make the sound by blowing across this little hole here, and lengthening or shortening the tube to get in. This is basically a 19th century invention, the flute. Throughout the 18th century and up to about 1850, the flute was a conical instrument made of wood. But as composers started writing bigger and bigger symphonies and concert halls got bigger and bigger, there was a need for more volume and more dexterity in the instrument. And Theobald Boehm came up with this idea in the mid 19th century of making a cylindrical flute out of metal, which gave you much more dexterity, was around much quicker, and it was a much more powerful instrument. So that's what he did, and that's what he came up with, and that's what we're still playing today. Well, there is an interesting story about how he came to invent this flute. He was not just a flute maker, he was also a very fine flute player and composer. And he came over to England in the early 19th century, and he had the opportunity of hearing a great English flute player who was called Nicholson. And Nicholson was playing on a wooden flute, but he'd done some strange things to his flute. He made all the holes a bit bigger, and he made this absolutely huge sound, and he played with great virtuosity. And so Boehm, who had never heard anything like it, said, he's got to do something about this, he's got to be able to combat this extraordinary flute player. So he went all the way home and started working on a new patent, which was going to be a metal cylindrical, much bigger holes than the wooden flutes of the time. And so he actually invented this flute with the sole purpose of playing faster and louder than this great English flute player. And, well, he did. He succeeded. Well, the Baroque flute was a conical wooden flute, meaning the body gets thinner as it goes down. The Baroque flute had just one tube here, and you have to run all the notes through holes in the tube, but you get all the notes just like combinations of your finger. It's a very simple instrument, and you get these wonderful notes called forked notes, where you have to have holes. It doesn't go just straight down like this, you have to have holes in between your fingers, which make very strange and weak notes and weak colours on them. And these actually give the Baroque flute a very expressive quality. Often modern flute players, when they talk about the Baroque flute, they talk about the inequality of the notes and the inequality of the sound on the Baroque flute as some kind of extremely expressive.
check, check. Check, check, check. Hello, check.
Tata AIG car insurance. Trusted now. Fantastic car.
We have recovered almost 60% of our abandoned cars.
Good morning, everybody. Welcome to the second day of our 2022 KRSSDI Diabetes Summit. So today we'll start in this hall B with the oral presentation by the our candidates, and we have a jury to assess them. So I request all the presenters to be around here, and if any of them have presented the same thing as a poster, please just inform us before, so you'll be given the chance last. If you have not presented, your oral presentation will be taken up for consideration. So I think we'll start with Dr. Jaishankar.
Good morning, everybody. I think we are all set to set the dice rolling. So before we start doing that, I think we will just speak about the ground rules with the permission of Sydney sir. Sir, we'll give a time of 6 minutes plus 2 minutes for question answer session, and we will be judging them based on concept and method, timing, impact. Okay, 7 plus 2.
7 plus 2.
7 plus 2, no problem. 7 minutes plus 2 minutes oration, and then we'll have a Q&A session. So we'll be totally marked for 100, out of which the top presenter is going to be awarded. So any changes or anything? Yeah, please, before we start, we should all be on the same page so that there is no confusion later on.
The question and answers will be for 2 minutes. Yeah. At the outset, let me congratulate each one of you for having taken this opportunity to come and present here. A huge round of applause to each one of you for this particular initiative. So as RSSDI, we all know, is more of a research organization. The aim for all of us is to promote the concept of research, get into this the lacunae that we have in our country right now is lack of research and publications. So it's with a huge honor that we have Dr. Sydney coming over, and he has been the backbone of making sure that this research goes on in a big way. And we wanted to also announce about the prize money and the publications that are there. So I would ask Dr. Sydney to talk a few words about why and how.
The very fact, the very name KRSSDI is not conference. Conference is part of it. The R stands for research, right? So unless there is a basic research, we start from your level. You know, things don't change. We always look at New England Journal of Medicine, Lancet, and all not. Where are our journal studies going on? We don't have that quality. Why? We always call money. Money is the problem. No, money is not a problem. Money is there. But problem is mindset is different. So to change that mindset, I thought we will do something. So our Department of Medicine in Yenapaya Medical College and Yenapaya University, we all pulled in money, our own money, plus university gave 50% of it. So we kept that corpus. So every year 10,000 rupees for the best research paper, which will go on every year. So I want that quality to improve so that, you know, people will get benefited out of it. You should spread this message. Thereafter, many people will come forward to give more rewards for that. So your quality of papers should go up. That's the only thing that we wanted to do it. As a past president or chairman, I instituted that prize, which will go on now. Now, regarding this timing, what time is the beep? Where is he? That beep will, what time you want the beep to be there? At the end of 6 minutes, right?
7 minutes.
Where is he?
7 minutes.
Total 7 minutes.
Okay.
ಆ ಬೀಪ್ 6 minutes ಬರಬೇಕು. ಎಲ್ಲಿದ್ರ? 6 minutes ಗೆ big ಬರ್ಬೇಕು. So they'll have 1 minute. Okay? Yes. Thank you.
Thank you, sir. I think Dr. Jaishankar, we will start. Can you start the clock, please?
Yes. Good morning, everyone. I am Dr. Jaishankar. I am HOD of General Medicine from Vaidhi Medical College, Bangalore. I will be presenting on prevalence of left ventricular diastolic dysfunction in normotensive type 2 diabetes mellitus patients. Now, introduction. Cardiovascular disease is the leading cause of death among individuals with type 2 diabetes mellitus. It is said that men with type 2 diabetes mellitus has 2 times higher risk of developing cardiovascular mortality compared to men without non-diabetics. In the same way, women with type 2 diabetes mellitus have 4 times higher risk of developing cardiovascular mortality compared to women without diabetes. Diabetic cardiomyopathy is a clinical entity characterized by abnormal ventricular function leading to CCF in the absence of coronary artery disease, systemic hypertension, or any pre-existing structural heart disease. Now, left ventricular diastolic dysfunction is the earliest and commonest hemodynamic derangement of diabetic cardiomyopathy, leading to significant morbidity and mortality in diabetic patients. Diastolic dysfunction refers to impaired left ventricular relaxation with or without increase of filling pressure. Now, these patients can be asymptomatic. This diastolic dysfunction can also occur in patients with preserved ejection fraction and patients with reduced ejection fraction also. I already told that most of the patients are often asymptomatic. That is, the patients with diabetes mellitus, diastolic dysfunction they will have, but they are often asymptomatic, and it's presently associated with a marked increase in all-cause mortality. Materials and method. This was a study done in Vaidhi Medical Research and Research Center, Bangalore, from January 2018 to 2020 for 1.5 years. It is a prospective observational hospital-based cross-sectional study. Patients with type 2 diabetes mellitus who are already diagnosed with type 2 diabetes mellitus, who are aged more than 18 years, or normotensive were included in the study. Patients with systemic hypertension, heart disease, history of heart disease in the past, patient who had angina, dyspnea, history, COPD, CKD, anemia, thyroid disorders, coronary artery disease, and type 1 diabetes mellitus, and along with history of smoking or alcoholism were excluded in the study, from the study. The following parameters were used in the study. ECG was done and 2-day course done for all the patients. In ECG, we calculated the P-wave duration, QRS duration, QTC interval. In the 2D echo, we consider the parameters for assessing the left ventricular function. That was, one is deceleration time, then ratio between early mitral inflow velocity and mitral annular early diastolic velocity, E bar, E dash, and pulmonary vein Doppler to see pulmonary vein flow velocity. We also estimated HbA1c for all the patients. The parameters what we used were deceleration time. So what is this deceleration time? It's the time interval from the peak of E wave to its projected baseline. Normally it ranges from 150 to 240 seconds. It indicates the duration for equalizing the pressure difference between the left atrium and left ventricle. Then there is something called as E bar E dash ratio. There is early mitral filling velocity to early diastolic mitral annular velocity. It's a simplified approach to estimate the left ventricular filling pressure. Normally it is less than 8. If it is more than 15 means there is increase in left ventricular filling pressure, which determines the degree of diastolic dysfunction. Then pulmonary vein flow velocity normally it was 80 to 120. It also is strongly related to left ventricular isometric relaxation time. Now results. We included 130 patients of type 2 diabetes mellitus. The mean age of the patients was 51.56 plus or minus 10.50. The overall prevalence of left ventricular diastolic dysfunction in these patients were 54.4%. The 72 patients had it. Out of the 72 patients, 69 of the patients had left ventricular diastolic dysfunction of grade 1, and the remaining 3 patients had grade 2 left ventricular diastolic dysfunction. None of the patients have grade 3 or grade 4. In our study, 95 were males, 35 were females, and there was a male dominance in our study. Out of the 35 females, 17 had left ventricular diastolic dysfunction. Out of 95, 55 had left ventricular diastolic dysfunction. Now this is the table showing the statistical significance. In our study, age, deceleration time, E bar E ratio, and QT's interval was statistically significant. This is the graph showing that deceleration time was more in patients with left ventricular diastolic dysfunction, and E bar E ratio was more in patients with left ventricular diastolic dysfunction, and QT's interval also was prolonged in those patients. Discussion. It is said that worldwide, by 2030, 4.4% of patients will be having the diabetes mellitus, and 80% of mortality in these patients is due to cardiovascular disease. It is estimated in patients with type 2 diabetes mellitus, they have 2.5 times incidence of heart failure, and this independent left ventricular diastolic dysfunction will be early predictor of imminent systolic failure, because the diastolic dysfunction will later do systolic dysfunction, and this is early predictor of imminent systolic failure. A few studies were done. One of the study I'm quoting is from the study done in 2013 by Nigeria, where DOT Manuel St. et al. Recruited 90 patients, and these patients were normotensive diabetic patients, and they also showed that the higher prevalence of left ventricular dysfunction in the absence of cardiac symptoms. It was around 51% in their study. This similar study was done by Patil VC et al. In India in 2011, where 227 patients were recruited, and they also showed higher incidence of left ventricular dysfunction in asymptomatic patients. But they found out that there was positively correlation with the duration of diabetes, HbA1c, obesity indices, and diabetic microangiopathies. Now, our study we included 130 patients, and in our study, the prevalence was 54.4%. Now, as I told you earlier, E bar E dash ratio, the deceleration time and QT's interval was statistically significant, whereas there was no statistical correlation between the LV dash dysfunction and HbA1c in our study. Now, the certain limitations were there. The specificity of this, whatever we use, conventional Doppler is 40 to 70%. For tissue, Doppler is more sensitivity and specificity compared to the transthoracic conventional Doppler study. We didn't do a coronary angiogram and treadmill test to rule out coronary artery disease, and we did only HbA1c, and the HbA1c gives the gives the average of 3 months blood sugars level. Other studies they consider duration of diabetes, but we didn't consider duration of diabetes for correlation. Then conclusion is, in our study 54.4%, which is similar to the studies done earlier in Nigeria, and all the patient type 2 diabetes should be routinely and repeatedly subjected to 2D Doppler echocardiographic assessment of cardiac function. So LV diastolic dysfunction can be used as an early indicator because it later leads to left ventricular hypertrophy and later clinical left ventricular heart dysfunction. So this has important therapeutic implications and helps physicians to plan early interventional strategies. These were my references, sir. Thank you very much.
So, right on time, sir. If I can ask a question,
yes,
did
sir.
you consider microangiopathies like
No,
the
sir,
other studies?
No, sir.
Any particular reason for that?
The study was, this was a dissertation actually. Okay. In this dissertation we only consider prevalence. I understand that the microvascular complications like microalbuminuria has a strong correlation with the prevalence of left ventricular arrest, but we didn't do it, sir.
Okay. Fundoscopy as a dissertation topic,
fundoscopy was not considered in this study, sir. We just estimated the prevalence of only this 2D echo and ECG we did, sir.
Okay. Even the TMT also is a non-invasive test. So, yes, I mean, probably it could have added more value to the study.
Yes, sir.
That is what is my conclusion.
Fantastic presentation, Dr. Jaishankar.
Thank you, sir.
Couple of questions. We very well know that left ventricular diastolic dysfunction is one of the commonest presentations for diabetic patients who are even asymptomatic.
Correct.
We also know that echo is got an inter-observal variations.
Yes, sir.
Now, how much of the interpretation by the performing cardiologist can be offset to take into consideration these vital parameters that we're talking about? So we talked about the deceleration time, we talked about the E1 ratio, we talked about these parameters. Now we know that between one cardiologist A and cardiologist B, there will be an inter-observational variability.
Yes, sir.
Now how much of that is a confounding factor to estimate your diastolic dysfunction?
So maybe
pretty high, like 1 in 2, almost 1 in 2 are having the same thing. So as sir said, the variability. How do what have we done to take that into consideration? So I am assuming all were done by the same cardiologist.
No, sir. No, sir. In our hospital, actually, sometimes the cardiologist they go for angiogram. So that time the patients, if they come to echocardiographic examination, it will be done by different cardiologists, sir. We didn't consider the same cardiologist, sir. That is, I understand, sir.
Thank you. The second question was, all these patients who had a diastolic dysfunction, though this was not the objective of the study, did you follow them up with a subsequent coronary angiogram to find out the presence or absence of a coronary artery disease in these individuals? Because we would have estimated the diastolic dysfunction prediction much earlier. So was there any follow-up study of these
No,
patients?
sir. Only few of the patients were followed because see, most of the patients in YDA hospital, they come from West Bengal, sir. They come, then they go out. So only few patients came, so around 30 patients came, sir. Remaining patients didn't come. I understand the clinical heart failure and diabetic cardiomyopathy is 12.8%, sir, 8%. But in our study, only 30 patients came, so I didn't consider the following of patients, sir.
The third and last question was, we know that diastolic dysfunction is more commoner in females.
Correct, sir.
But in your study of 130 patients, there was a male preponderance.
Correct,
was there any selection bias?
No, sir. There was no selection bias in that. I understand the females, females, and the studies show that actually more common in females because the estrogen has an effect over it, sir. And most of these patients were actually, if you look at the mean, it is actually ages between 40 to 50 years, and they are in the menopausal age. So I do understand the patients with females, they should have more of LV dysfunction due to cardiomyopathy. But in our case, it was male patients, sir. I understand the estrogen has a protective effect over the left ventricular diastolic dysfunctions.
Fantastic.
Thank you, sir. Thank you, sir.
Thank you.
We go on to the next one, Dr. Arya Satish. So we go on to the next one, Dr. Mahim Shetty. Dr. Mahim Shetty is there. Okay.
Morning everyone. Myself Dr. Mahim from JSS Medical College, a postgraduate. I am going to present my oral presentation on topic pulmonary arterial hypertension as a predictor of severity of chronic kidney disease and correlation with its various stages. As we know, pulmonary hypertension refers to presence of high pulmonary vascular pressures and can be the end result of a variety of different underlying disorders. Under them, it can be cardiovascular, respiratory disorders, chronic thromboembolism, and apart from that, multifactorial causes. And as we know, CKD is a highly inflammatory state and hyperdynamic state. It increases the risk of cardiovascular mortality and morbidity by 200-fold. And according to the Indian data, the most common causes of CKD in India are diabetic nephropathy, followed by chronic glomerulonephritis and hypertension. In our study, the prevalence of pulmonary arterial hypertension in patients with CKD was evaluated. Along with that, association of PAH with CKD etiology and the prevalence in different stages was also evaluated and correlation with different stages. We included patients, 60 patients who belong to stage 3 and above as per the Kidney Disease Outcome Quality Initiative guidelines and were above 18 years. We had a large exclusion criteria in which we excluded patients who had prior respiratory disorders, cardiovascular disorders, pulmonary thromboembolism, that is CTEPH, and a patient who had acute kidney injury, polycystic kidney diseases, burns and sepsis in pregnant females. Nextly, it was a cross-sectional study done at our hospital from December 2021 to June 2022. And after classifying the patient as per KDOQI guidelines, we grouped them accordingly in the mild, moderate and severe groups. And after this, the association with the CKD etiologies was also assessed. Next, coming to the demographics and clinical data, we had 60 patients, and apart from that, mean age of the population was 51.6, and out of 60 patients, 52 had pulmonary hypertension, which accounted for approximately 86%. Then, as we can see in the graph, we had major chunk of patients which belong to stage 5D, followed by stage 4, which accounted for approximately 23.3%. This is depicted in the graph showing patient maximum belonging to stage 5D. And this is the distribution of study subjects based on the grading of pulmonary arterial hypertension. Most of them had mild pulmonary hypertension and the mean pulmonary pressures were 50.83. Next, coming to the relationship between the stages of CKD and pulmonary hypertension, as we can see, in the initial stages, that is stage 3B, only 6 patients did not have pulmonary hypertension. But as we go on the higher stages, all the patients which belong to stage 5 and 5D had pulmonary hypertension, and we had a significant p-value. This is being depicted in the initial stages. Less number of patients had pulmonary hypertension, but as we go on the higher stages, all the patients had pulmonary hypertension. Next, establishing a relationship between HD and PAH, we had out of 60 patients, 33 patients on hemodialysis, including AV fistula as well as through jugular or jugular catheter. And we had a significant p-value. Nextly, this is depicted in the graph. Now, when we compared to the comorbidities, the major chunk of the patients had hypertension and diabetes. And the patient, out of 60 patients, 56 had hypertension and 42 patients had diabetes. And approximately 92% of patients having hypertension had pulmonary hypertension, and 60% had diabetic with pulmonary hypertension. Then if we compare our studies to the different studies, first study was done in Maharashtra in 2013 to 2017, which was done by Kalpana S. Mehta, which also showed serial elevation of pulmonary pressures as we go on the higher stages, which was 9.91%, followed by 21% and 68.5%. And as we can see in our study also, we had 33 patients who were on dialysis, and they had higher pulmonary arterial hypertension, which was similar to the other studies. And the other study, which was conducted by Kalpana S. and Fabian in US, it was also showing that incidence of diabetes and hypertension was more with the CKD etiology. Lastly, coming to the conclusion, our study revealed that approximately 86.7% had pulmonary hypertension and CKD with a mean pulmonary pressure of 50.83. And as the stages advanced, the incidence of pulmonary hypertension increased, maximum seen in stage 5D. And if we compare it to the persons on hemodialysis, compared to conservative management, the persons on HD had a higher incidence. Lastly, coming to the limitations of the study, our study population did not include CKD patients who belong to stage 1 or stage 2 and who were on peritoneal dialysis. Lastly, we did an indirect echocardiographic measurement of pulmonary pressures, and it was not done by the right heart catheterization. And the study sample was very small, and being a cross-sectional study, we could not go ahead with the follow-up of the patient. And lastly, the study was done to see whether once the magnitude of pulmonary hypertension in CKD is determined at early stage, we can prevent the cardiovascular mortality and morbidity. These are my references. Thank you. Stage 3, stage 4 and stage 5, sir. Yes, sir. There are not. Yes, sir. Sir, as the stages advance, we need to prove that pulmonary arterial hypertension increases. So that.
What's the title of your study, doctor?
Sir, to assess the severity of pulmonary arterial hypertension, as the first we need to assess the severity of pulmonary.
Put your title slide.
Yes, sir.
Yeah, read your title.
So, pulmonary arterial hypertension is a predictor of severity of chronic kidney disease and correlation with its various stages, sir.
Got it?
Yes.
Now, listen to what's the question that is being asked by Dr. Sidney. What's the question?
Sir, as the predictor of CKD.
Right.
So,
when do you predict? You need a predictive analysis in the early stages of the disease.
Yes, sir.
So, when you have said that there is stage 3, stage 4, stage 5, as the disease progresses, there is an increase in pulmonary arterial hypertension.
Yes, sir.
Does that have any therapeutic implication at that stage?
Yes, sir. With the initial stages, for example, if we are detecting it in the stage 3 or stage 4, we can, it is mainly associated, depends upon the etiology of the disease, whether it is diabetic kidney disease or hypertensive. And if we start treatment at an early stages, we can prevent LV diastolic dysfunction and cardiovascular mortality and morbidity. We can reduce them.
Perfect. So let's understand this. The objective of any study that we do needs to have either a diagnostic implication or a therapeutic implication.
Yes, sir.
Now, the therapeutic implication is more profound if you are able to do an early predictive analysis.
Yes.
Now, if the same study were to have included your stage 1, stage 2 and stage 3 patients, and if you had done an earlier predictive analysis of these patients, picked up the evidence of pulmonary arterial hypertension, started interventions at that stage, you would have obviously prevented or prolonged the onset of pulmonary hypertension going on and getting on into this. So what you've done is you've mimicked the earlier studies that are there and tried to see what is it that you have as a statistics. Your research as such is good, but what we are trying to see is how could it be improved is to make sure that if it can have an additional therapeutic implications.
Yes, sir.
Right? So that is one of the points that you need to consider whenever we're doing a research. Now, did you have any correlation between the duration of chronic kidney disease in these patients from stage 1 to stage 5? Did you take a correlation of the
Yes, sir.
duration?
Yes, sir. Because of the time constraint, I did not include it. There was, in general, what we see as the duration of chronic kidney disease increases, the pulmonary arterial hypertension will increase as CKD is an inflammatory state and due to the hyperdynamic state and volume overload condition. The prevalence of pulmonary hypertension increases, sir.
So did you see any kind of a negative correlation?
Yes,
where,
sir.
Yeah, what
yes,
is
sir.
it?
In our study, there was a negative correlation, sir. We had the number of patients having pulmonary was more than more than 12 months. There was significant number of patients, but it was not statistically significant, sir. So that's why I did not include it, sir.
Okay, doctor.
I just wanted to see your exclusion criteria once.
Yes, sir.
So you did a CTPA for everybody?
No, sir.
No, I just wanted to see that. I wanted to see your exclusion criteria. No, in the exclusion, I think he did mention about that.
So the respiratory disorders were ruled out. Then secondly,
So, probably theoretical, but silent pulmonary thromboembolism, because we know CKP and you have included stage 3 plus, so not stage 1 and stage 2. So silent pulmonary thromboembolism, how have you excluded?
sir, based on the
So basically you need to, all the patients who are included should have a CTP. I'm just
Yes, sir.
for discussion's sake,
Yes,
but I am very sure it is not a viable thing,
Yes, sir.
because everybody can't be
Yes,
done that. I just wanted to know about that. Again, correlation with other complications like retinopathy.
Yes, sir, it was there, sir, but mainly because we had included everything, but because of time constraint, I included the major portion only, sir.
Because how many of them had probably moderate or severe PDR?
Yes, sir, they had, sir. Approximately we had a total of 46 patients with diabetes, and in them 30% had diabetic nephropathy, and apart from that, retinopathy was seen in 34%, sir.
So how many of the people who had diabetes had diabetic retinopathy as well?
Sir, approximately 31%, sir.
No. Of the patients who had diabetes, how many of them had retinopathy as well?
21, sir, total 46 patients of diabetes, out of them 21 had retinopathy as well.
And 34 had CKD.
Nephropathy, 34% of them had nephropathy also.
Okay, the correlation was quite less.
Because our sample size was less, as our study duration was only 6 to 8 months, so and it was a cross-sectional study, and we had a lot of exclusion criteria.
So last question, do you think it has therapeutic implications?
Yes, sir. We can predict, because if we detect at an early stage. For example, diabetes and hypertension leads to LV diastolic dysfunction. So if we control diabetes and hypertension at an early stage, we can prevent that LV diastolic dysfunction, sir.
Okay, thank you. We go on to the next one, Dr. Srinath KM.
Very good morning to all of you, respected chairpersons. I bring greetings from my institute, JSS Medical College. The topic which I am going to present now is the effect of vitamin D on cytokine profiling in diabetic as well as diabetic nephropathy. My guide is Professor Basavanagadappa, Principal, JSS Medical College. We all know diabetes is a chronic metabolic disorder with an inflammatory component added to it, and its prevalence is increasing day by day and has reached the epidemic proportion right now. And we all know its effects, particularly the complications like microvascular complications like diabetic nephropathy is an important cause for end-stage renal disease. So diabetic nephropathy is considered as a non-immune disorder. Of course, increasing evidence suggests that inflammatory mechanisms they may play a major role in the disease pathogenesis as well as the progression. Identification of cytokines not only alters the classical but also gives fresh insight into the pathophysiology of various autoimmune disorders. And monitoring diabetic nephropathy, which is predicted by microalbuminuria as well as vitamin D and cytokine levels, could be a strong early biomarkers. So probably early diagnosis can help to prevent this particular kidney disease from getting worse. So in this context, we aim to estimate the levels of interleukins, particularly IL-1, IL-6 as well as N2NF alpha, and vitamin D levels among diabetics with and without nephropathy. So we did compare the interleukins with vitamin D levels in diabetics with and without nephropathy. Of course, it is a comparative cross-sectional study done among 3 groups. Group 1 is diabetics, number 2 is diabetic nephropathy, third group included healthy subjects which attended master health checkups of JSS Medical College. So we did consider a sample size after consulting a statistician. The mean values of vitamin D among patients with diabetes as well as diabetic nephropathy considered to be 19.82 plus or minus 5. The sample size was calculated for multiple comparison of biochemical parameters using ANOVA, followed by post-hoc multiple comparison procedure. The sample size required at 5% level of significance with statistical power of 0.8. In addition to that, absolute standardized mean difference of 0.5 is found to be 246 with 82 samples per each group. So thus we included 84 diabetics with nephropathy and 84 age and sex matched controls, which apparent they were the healthy individuals included as a comparison group. Inclusion criteria for diabetics, we utilize the standardized WHO criteria of fasting blood sugar more than 126, ppbs of more than 200, and HbA1c of more than 6.5%. For a diabetic nephropathy group, we consider patients who are diabetic for more than 4 years and diabetics with GFR of less than 90 ml per minute per 1.73 meter square with proteinuria. This based on the MDRD formula. The controls were the normal subject without any disorders. The exclusion criteria was patients who had a pre-existing renal, hepatic or cardiovascular dysfunction. Patients with tuberculosis, HIV as well as sarcoidosis, other infections were excluded. Drugs that interfere with vitamin D metabolism, especially anti-epileptic, antipsychotics as well as even rifampicin and INH were excluded. The patients who are already on vitamin D supplementation for the last 6 months, they were also excluded. And patients who are on nephrotoxic drugs, like ARTs and even anti-malignant drugs, they were excluded from the study. So we did do a biochemical investigations like fasting blood sugar, PPBS, HbA1c levels to determine the diabetic status and also to identify the controls. We also did urea, serum creatinine and UACR, urine albumin creatinine ratio, to determine the status of diabetic nephropathy as well as its stages. So we did estimate vitamin D levels, especially by chemiluminescence method, and we also estimated the cytokine levels as IL-1, IL-6 and TNF-alpha by ELISA methods, by using special ELISA kits. So each group has 84 number of patients. So look at this is vitamin D deficiency, where severe vitamin D deficiency is considered as less than 10 nanogram per deciliter. Vitamin D deficiency is considered as 10 to 20. From 20 to 30 we considered as an insufficiency. So more than 30 is considered as a normal. So in the control group, most of the study groups they had vitamin D deficiency. If you just look at the control group, the deficiency was almost 42%, whereas in diabetic it was almost 60%, whereas in nephropathy it is 51%. But if you look at the serum vitamin D deficiency that is very severe, is found in nephropathy group. So we did serum cytokine levels, IL-1, IL-6 and TNF-alpha. The IL-1 as well as TNF-alpha were more in the diabetic group, whereas IL-6 was more in the nephropathy group. We did a sub-analysis of vitamin D deficiency, optimal, suboptimal, deficient and very severely deficient. So in that, so IL-6 were more in nephropathy group compared to diabetic and control group, whereas TNF-alpha was more in the diabetic group compared to diabetic nephropathy group. This is what the blocks plot, which is showing the various, especially the vitamin levels. These are the group 1, group 2, group 3, the sub-analysis of based on the vitamin D deficiency.
Sir, time's up. Please summarize.
At the end, I'll conclude that. So majority of the patients in our study had vitamin D deficiency, but severe vitamin D deficiency was observed in diabetic nephropathy subjects. Interleukin 6 were high in diabetics with nephropathy, whereas interleukin 1 and TNF-alpha levels were high in diabetic group. Hence, IN6 can be considered, may be considered as a potential early marker of nephropathy. We thank SERB, the Government of India, for providing fund for this research group. Dr. P.V. Salimat was the PA for the PA project, and myself and Basangoda sir was the co-PIs for this project. Thank you.
Fantastic, Dr. Srinath. It's a very detailed presentation of a research paper. The parameters that you considered were vitamin D. What form of vitamin D was assessed? What form of vitamin D was assessed?
So actually the vitamin D assessment is only it is not the active form. We cannot assess the active form. Only the vitamin D2 can be assessed when the available this thing. So we could assess only the D2. And this is done across the globe. Whatever the people are assessing, it's only the vitamin D2. Not the vitamin D3. Vitamin D3 is the form with one which acts at the cellular level.
Right. So the second question that we wanted was the correlation between vitamin D and cytokines. What was the net correlation that you found between the diabetic groups and the non-diabetic groups? Was there any assessment that was done?
Yes, that was done. There was a weak negative correlation for IL-6 in nephropathy group, whereas TNF-alpha as well as IL-1 has got a weak negative correlation in a diabetic group. Possibly because in a diabetic group, even TNF alpha and is especially contributed by the intrinsic cells of the kidney, particularly mesangial cells or endothelial cells, other intrinsic cells of the kidney. At the end stage of the kidney, these cells are defunct. They may not be producing these particular proteins. And the limitation of our study is we could not measure the urinary levels of IL-1, IL-6 as well as TNF alpha, which could have given more better results. Because during later stages of the CKD, there will be more proteinuria. These amount of proteins may be lost in the protein. That's why we were not able to dogmatically say this could be an early marker.
And what was the duration of the study and the time? When was the
So
study?
almost 3 years, sir. We did 3 years from 2019. In between, for 1 year, we could not collect cases because of the pandemic.
So that was a question that I wanted to find out. Was there any effect of the pandemic disorder as such as a residual inflammatory marker in these diabetic subset of patients? We all know that.
So, yeah, we could not collect. So majority of the patients, 60% of the patients we collected from 2018 to 19 before the pandemic set in. Okay. After the pandemic, we could collect only the 30% of the patient, even after 1.5 years. Because none of the patients, especially CKD patients, they visited a hospital. That was the reason.
And what is your therapeutic implication for this study that you have?
Yeah, we are considering, actually this is a part of the study. So we did estimate even antioxidants also. Antioxidants like catalase and GPX as well as glutathione peroxidase and reductase. So we just wanted to see, we know CKD is basically an inflammatory disease. Diabetes is also an inflammatory disease. And whether these inflammatory processes are contributing. Suppose if you can pick up these things in an early stage, well, can we do any therapeutic target for such markers? Do we have any biologicals? Can we use particular?
Diabetes, it has been well established that it is a inflammatory disease. So
Correct.
we are probably establishing the already established fact by giving evidence.
Correct.
So that is one thing. Second thing I wanted to know, sir, in the diabetic nephropathy group, did you consider doing a PTH? Because vitamin D and PTH are related.
That is a one limitation of our study. We did not do PTH. So
Hyperpara
probably by doing PTH and serum calcium as well as bone marrow density would have given a better added value for this study. That is what I'm saying. Because normal nomogram has not been established for vitamin D. We are searching because that is a paradox in India. See, this sunshine vitamin is deficient in sunny India. Why, being Indians, we have a lot of sunlight, why still we are having a deficiency?
Still do the BMD and PTH in these patients so that we can probably understand the role of IL-1, IL-6 and tumor necrosis factor as a part of probably nephropathy and
correct.
What role it does.
Yes, sir, we are considering that because we have a list of all these patients and we can call them back and do, and we are getting a BMD instrument in our hospital. So we are planning to do that.
Thank you, sir. We'll go on to the next one. Thanks a lot, sir.
Thank you.
We go on to the next one, Dr. Venkatasai Shashank. We'll skip. Okay. So we'll go on to the next one, Dr. Aishwarya.
Good morning, everyone. I'm Aishwarya. I'm from JSS Medical College, and I'll be presenting on association of monocyte to HDL cholesterol ratio with vascular complications in patients with type 2 diabetes. My guide is Dr. Ravikumar Vyas. He is Professor and HOD, Department of General Medicine, JSS Medical College. So diabetes mellitus is a chronic metabolic disease commonly associated with both micro and macrovascular complications. The systemic inflammation has a significant role in development of these vascular complications. Several pathophysiological factors such as polyols, hyperglycemic protein glycation, the formation of advanced glycation end products, and ischemia operate together for the development of vascular complications in diabetes. Advanced glycation end products are pro-inflammatory molecules that lead to oxidative stress and induce the production of cytokinins like interleukin-1, interleukin-6, and TNF-alpha by activating cell types like monocytes, which have both pro-inflammatory and pro-oxidant effects, causing the progression of vascular complications. The high-density lipoprotein cholesterol diffuses these pro-inflammatory and pro-oxidant effects of monocytes by counteracting and inhibiting the migration of macrophages and oxidation of LDL cholesterol, as well as promoting the efflux of cholesterol from these cells. A relation between high number of monocyte and low HDL levels have been reported in various inflammatory disorders. And the monocyte to HDL cholesterol ratio is a novel and composite predictor that can reflect the balance between the inflammatory and oxidative stress of both monocytes and HDL cholesterol. It is cheaper compared to other inflammatory markers, and it is easily accessible. We can calculate it from the absolute monocyte count from total counts and HDL cholesterol from lipid profile. In the present study, we aim to investigate the relevance of MHR as a marker to assess the vascular complications in patients with diabetes. Coming to the objectives, the primary objective is to study the association of monocyte to HDL cholesterol ratio with vascular complications in patients with type 2 diabetes mellitus. And secondary objective is to study the role of MHR as a novel and cost-effective inflammatory marker in detecting the vascular complications in diabetics. So materials and methods, it is a hospital-based cross-sectional study, and a total of 100 patients with type 2 diabetes mellitus were included in this study. And based on the inclusion and exclusion criteria, the inclusion criteria being age more than 18 years and patients who are diagnosed as type 2 diabetics for 5 years or more, and exclusion criteria being hematological disorders, malignancies, severe liver and kidney diseases, cerebrovascular diseases, cardiovascular diseases, connective tissue disorders, acute inflammations, and active psychiatric illnesses, and patients who are on lipid-lowering drugs or statins, steroids. The study population was subjected to routine investigations like complete hemogram, LFT, RFT, lipid profile, FBS, PPBS, HbA1c, biothessiometry, Doppler, and echo, and urine albumin creatinine ratio. The patients were divided into patients with complications and without complications. And for all patients, MHR has been calculated from absolute monocyte count from complete hemogram and divided by HDL ratio from lipid profile. The normal MHR in non-diabetic patients was 7.2 with a standard deviation of 0.9. So microvascular complications, we have done spot urine microalbumin creatinine ratio for diabetic nephropathy, and if spot urine microalbumin creatinine ratio of more than 30 mg per gram was considered to have diabetic nephropathy, and for diabetic retinopathy, fundoscopy, direct fundoscopy was done, and for neuropathy, tendon reflexes, 10 gram monofilament, and biothessiometry was done. For microvascular complications, for cardiovascular diseases, clinical symptoms were asked, ECG and echo were done, and peripheral vascular diseases, clinical symptoms, peripheral pulses were felt and looked for, and ankle brachial pressure index with the help of Doppler was calculated. So these are the results. Most of the study population were between the age of 51 to 70 years age, and most of them were males, about 53 are males. And the distribution of different parameters among the study population. So the mean systolic blood pressure was 122, diastolic blood pressure was 78, and monocytes mean was 371.88 with a standard deviation of 171, and HDL was 31 with a standard deviation of 12, and MHR was 15. This is the mean MHR. So out of the all patients, like we had 63 patients showed vascular complications, and 57 had microvascular complications, and 23 had macrovascular complications. The MHR value in vascular complications was 19.68, and those without vascular complications, we got it a value of 8.42, and it is significant. And in microvascular complications, it is a 20.68, and macrovascular complications was 20.41. And for all three, the p-value was significant. And these are the individual complications which we have evaluated. And for out of all the patients, the most common complication we got as diabetic neuropathy. 48 had diabetic neuropathy, followed by diabetic nephropathy and retinopathy. And the MHR was calculated, and for all these patients with complications, it is from 20 to 25, and without complications, it was in around 12. So for all these, it is clinically significant. So results out of 100 sample size, 63 diabetics had vascular complications and 33 did not have complications. 57 showed microvascular complications and 23 had macrovascular complications. The mean MHR value was higher for patients, diabetic patients with vascular complications compared to those diabetics without complications. It was around 19.68 versus 8.4, which we got in patients without complications. The mean MHR value was higher for the diabetic patients with micro and macrovascular complication, and it was clinically significant. So conclusion, our study showed that MHR in diabetes with vascular complications was significantly higher than those with diabetics without vascular complications. This MHR ratio is a simple and valuable tool as a predictor for vascular complications in diabetes with micro and macrovascular complications, and it can be carried out even in remote areas where facilities for optimal evaluation of vascular complications do not exist. Thank you.
It deserves a huge round of applause, Dr. Aishwarya, for this fantastic study that you have done, which has got a very, very novel concept and a tool that can be used in the most remotest of places. So congratulations to you on that count. The question that I had for you was, your study population had duration of diabetes more than 5 years,
Yes.
presuming that that's the timeline that is required for everyone to develop a microvascular and macrovascular complications. Point number one. Point number two, all your diabetic patients were in the age of 51 to 70 years. Now, out of all these patients, none of these patients were put on statins, and that's the inclusion criteria, that's one of the exclusion criteria that you've taken off. Now, is that not a disservice to the patients who have been
Yes, sir.
diabetic patients more than 5 years, assuming that they have all these things, and then they have not been on statins?
Yes, sir. Ideally we have to start them on statins, but these are the patients who has come to our hospital setting and they were not on statins, sir, and that's why we had included them in our study.
Okay. Now, the problem for us is to find such kind of a population, right? Now, invariably, as per the standard recommendations, everyone above the age of 40 years, irrespective of their dyslipidemic status, they need to be on statins. Now, do you have a similar implications of this in spite of these patients being put on statins? Do you have a similar kind of a correlation that can be made? Or the addition of statins in these patients alter this ratio?
I think addition of statins alter the, not much, sir, because statins usually don't act on HDL that much, but there is a little elevation with statins. Maybe if at all it is included, then there can be a little difference if at all.
So a suggestion here would be to see if you can have a similar kind of an impact on patients on statins. And if you're able to prove that, it would definitely be a very good study that can be taken and used as a standard marker that can be recommended.
Yes.
Please, can you go back to the slide where you showed the mean blood pressure was 130 and 100 patients of 5 years
And
duration?
they are hypertensive patients, sir, but who are in control, like their BP are in control. Those are the patients which we have included.
Yeah, I think you did not mention that. I was
Yes,
a little surprised that out of 100 patients,
No, they are
none
all,
of them, the mean BP was 130. So that was a little surprising.
They are hypertensive patients, sir, but they are in well control.
I mean, as sir said, I'm sorry, but they are so well controlled that they're not on statins, but their blood pressure is well controlled. To get that subset of population wherein BP is so awesomely controlled, but they're not on statins. I mean, that's one probably thing is stinging in the eye. But other than that, yeah, really, if it comes, as sir said, if you can do it with statins and then show that if the numbers come to be pretty significant, then yes, it would be a study worth publishing. But I'm a little concerned with respect to blood pressure being so well controlled and patients are not being on statins.
The other question that I had was there any difference that you found between these ratios between your well-controlled diabetic individuals and poorly controlled diabetic individuals? Was there any sub-analysis that you did?
No, sir. We have not done a sub-analysis on that.
Right. So what we are trying to see is the correlation between this to assess vascular complications, right? So we wanted to also understand, in addition to control, I mean, in addition to the duration of the disease, whether a good control has got any altered ratio versus a poor control having a higher ratio. If that can also be sub-assessed, you can also add that as one of the predictive parameters that you could probably publish.
Our mean HbA1c in those patients was about 9, sir. So they are
all
not
poorly controlled.
Poorly controlled.
Okay, and if you could do that amongst patients who are well controlled with HbA1c 7, 6.57, and if you're able to see if there is any changes in these ratio, it is worth exploring.
Yes.
Thank you very much. A wonderful study nevertheless.
Thank
You so much, Dr. Aishwarya. So let's move on to Dr. Tejasvi. Yeah.
So, very good morning to all the dignitaries. I'm Dr. Tejasvi, medicine postgraduate from JSS Medical College. I'm here to talk about the topic, a comparative study of platelet volume indices in type 2 diabetics with and without vascular complications. The study was done under the guidance of Dr. Ravi Kumar sir.
Sorry, just a second. I think now there have been guidelines that we do not use the term type 2 diabetics. We say people with diabetes. So henceforth, for everybody, I think that should be
Sure. So it was done under the guidance of Ravi Kumar sir, professor and HOD Department of Medicine in JSS College, Mysore. Coming to the background of the study, we all know that diabetes today has assumed epidemic proportions and India has emerged as a diabetic capital of the world. So, and diabetes affects many organ systems over time, leading to serious micro and macrovascular complications. The pathogenesis of diabetes is complex and it has a strong interplay between metabolic, genetic, and environmental factors. Recently, platelet dysfunction in diabetes is being considered as one of the important etiologies in developing these complications. Platelet dysfunction in diabetes is caused by several mechanisms like hypoglycemia, insulin deficiency, obesity, dyslipidemia, dysregulated signaling of metabolic pathways, oxidative stress, and accelerated platelet turnover. As we all know, diabetes is a prothrombotic stage, and a hyperactive platelet is the phenotype, is an important epitope of this prothrombotic state. So young platelets are larger in size and contain denser granules, which release more of serotonin, beta thromboglobulin, and thromboxane A2. This makes larger platelets enzymatically and metabolically more active than smaller ones, and hence play a critical role in pathophysiology of this thrombotic state. So with larger platelets being hyperactive, evidence from the prospective studies and meta-analysis suggests correlation between the volume indices of platelets, like mean platelet volume, platelet distribution width, and platelet large cell ratio, and increased risk for thrombosis in patients of diabetes mellitus. So our objectives for the study are, the primary objective is to study the correlation of this mean platelet volume, platelet distribution width, and platelet large cell ratio in type 2 diabetic patients with and without complications. And the secondary objective is to correlate between these platelet indices in patients with micro and macrovascular complications. Coming to the methodology of our study, it was a hospital-based comparative cross-sectional study conducted over a duration of 18 months in both outpatients and inpatients of JSS, fulfilling the eligibility criteria. The sample size was 125, and patients who were already known diabetics were taken, and they were divided into two groups with and without complications. Necessary approval was taken from the ethics committee. Informed and written consent of the patients were taken, and all the data collected was kept confidential. All the clinical and lab data was documented in a pre-tested proforma. The parameters assessed in our study are the MPV, PDW, and platelet large cell ratio were obtained through a routine investigation performed, that is a complete hemogram. Patients were also assessed on their age, gender, duration of diabetes, FBS, PPBS, HbA1c when fasting lipid profile. And also the further assessment of the complications was done on coronary artery disease based on the clinical symptoms, ECG and 2D echo, and the peripheral vascular disease by the clinical assessment and ABPI by Doppler method. Diabetic retinopathy assessment was using the fundoscopy. Diabetic neuropathy, the clinical signs and symptoms along with the vibratory sensation test and the monofilament 10-gram test. Diabetic nephropathy patient by the quantitative UACR values in the morning spot urine samples and the serum creatinine levels. Coming to the subject eligibility, the inclusion criteria of a study contains patients above 18 years of age who are already known diabetics for more than 5 years with or without complications. And the exclusion criteria being females with hemoglobin less than 10 grams and males with HB less than 11 grams. Pregnant women, patients on antiplatelet drugs, patient presenting with acute febrile illness who are already known IHD and cerebrovascular accidents were excluded, and with those with diagnosed malignancies, septicemia, thrombocytopenia, thrombocytosis, thyroid disorders, chronic renal failure and cyanotic heart diseases were excluded. Coming to the results, majority of our patients fall in the age group between 51 and 60 years, and 54% were males and 48% for females. Coming to the glycemic index, 58% of them fall between the 7.1 to 10% of HbA1c, the mean being 9. And out of 125 patients, 60 had complications and 65 patients were without complications. This is the distribution of our diabetic complications. We had 7 patients who had peripheral vascular disease, and there were none with CAD. We have excluded known coronary artery disease and cerebrovascular accidents in our study and thought to consider only newly detected CAD. So apart from that, none of them were CAD. And coming to diabetic nephropathy, 34 were having diabetic nephropathy, 32 with retinopathy and 32 with neuropathy. This was the association of mean platelet count with diabetic complications. The overall picture suggests that platelet count was significantly reduced in patients with peripheral vascular disease and diabetic nephropathy and compared to other complications. This is the mean platelet volume which is studied. It is shown that based on patients without complications and with complications, it was significantly elevated in patients with microvascular complications than the macrovascular. Coming to the platelet distribution width, it was studied in patients without complications, it was low, and with complications it was increased, and significance was shown in only the group of diabetic neuropathy. Coming to the platelet large cell ratio, compared to the without complications, it was elevated in patients with complications and significantly elevated in both micro and macrovascular complications. We also assessed platelet indices in subjects who had hypertension. The most common additional comorbidity we found was in hypertension. So we found MPV was increased in patients with hypertension. And there was a positive correlation between platelet large cell ratio and total cholesterol and also LDL. Coming to conclude my study, it was showed that platelet indices such as MPV, PDW and platelet large cell ratio are elevated in patients with diabetic complications as compared to those without complications, and they are more significantly elevated in subjects with microvascular than macrovascular complications. Coming to the limitations, the major hindrance of the study is normal healthy population were not recruited. So only correlation was made between diabetics with and without complications. And it could not establish a causal relationship between increased indices and diabetic complications. Also, CVA and IHT were not included. So majority we studied among the microvascular complications than the macrovascular complications. These were my references, sir. Thank you.
Congratulations, Tejasvi. It's a well laid out study. My observation here was, this was a study done over 18 months.
Yes, sir.
It included outpatients and inpatients from a tertiary patient referral center where you will have nothing less than 25,000-30,000 patients per month. And the study was over almost close to 2 years.
Yes, sir.
And you have selected 125 patients.
Yes, sir.
Any reason?
That is based on the incidence and prevalence of the it was calculated by that data, sir, of diabetic complications.
Do you mean to say that you had only 125 patients who had a combination of these diabetic neuropathy, nephropathy, retinopathy as a subset in your study?
Not that way, sir.
Okay.
Like based on the analysis and the prospective and meta-analysis studies, we have seen 125 subjects would suffice this study.
Okay. That was the way it was. Now, when you found out that this particular indices that are significant in patients who have complications, does this indices change with the presence of 1, 2, 3 and plus coronary artery disease? Did you get my question? If they have only neuropathy,
okay,
only nephropathy, or a combination of neuro, nephro and retino,
yes, sir,
in addition to coronary artery disease,
yes, sir,
does these indices change?
So majority of our patients, those who had nephropathy also had retinopathy, also had neuropathy.
Correct.
So it was not individually, we couldn't individually study the complications in any of the patients.
Correct.
So majority of the patients who had nephropathy had also retinopathy and also neuropathy. So there were only few subset of patients who had individual complications.
No,
so
the question was, does the indices change when the number of complications are more, and is it less when there are less?
Okay.
Is that an observation
yes,
that you
sir.
made?
Yes, sir, but we couldn't observe that individually, sir, because majority had complications, like 2 or 3 complications there.
Okay, I know that you're trying to say something which you've not looked into, that's what
Yes,
it appears
yes,
to
sir.
be. But what I also want to understand was, is there any method where you have added them on antiplatelets? Using antiplatelet, 1 or 2 antiplatelets, does this study give us any indication towards a recommendation to start antiplatelets as putting them on 1 or 2 antiplatelets based on this study? Does that help?
Sir, I feel that in this study we couldn't establish the duration and the indices per se. So I feel that there are many other factors which are contributing to this complications apart from the platelet volume indices. So definitely we can start the patient based on this on antiplatelets, but that how does it differ the progress of the patient is not established. Like the cause and effect is not established. The direct causal relationship with the platelet and the complications is not established.
The same thing what sir wanted to ask, I wanted to ask, sir has asked, what happens if there is only neuropathy? Because nephropathy and retinopathy go hand in hand
Yes,
most of the
sir.
times,
Yes,
90% of the times. But only neuropathy if it was there, and combination of others, can we have a comparison and say, yes, it is more here, it is less here?
Yes, sir. I
because
think
neuropathy, 60% of the patients of diabetes will have neuropathy.
Yes.
5 years is pretty good time.
Yes, I think we should have studied individual groups would have helped us, individual complications would have helped us better. So.
Okay, thank you.
Yes.
Next we go on to Dr. Sara Shaukat.
Good morning, everyone. My name is Dr. Sara Shaukat Ali, and I'll be presenting on extracellular fluid to total body water ratio and pulse pressure in patients with varying degrees of proteinuria and normal creatinine in type 2 diabetes mellitus. My guide is Dr. Sydney D'Souza. So coming to the introduction, as we all know, type 2 diabetes mellitus is one of the leading cause of end-stage renal disease. And proteinuria, especially microalbuminuria, is an early sign of renal injury. In this...
Could you go back to your title?
Yes.
Can you read that once more?
Extracellular fluid to total body water ratio and pulse pressure in patients with varying degrees of proteinuria and normal creatinine. in type 2 diabetes mellitus patients. So, proteinuria is one of the early signs of microvascular injury, early signs of renal injury, and decrease in albumin usually leads to extravascular shift of the fluid, and there will be an extracellular fluid overload. So, there have been studies showing that pulse pressure and mean arterial pressure has been assessed for the risk of proteinuria or nephropathy, and it has been proven that mean arterial pressure increases with proteinuria. So coming to my research objective, it is basically to assess the relationship between extracellular fluid volume to total body water ratio and pulse pressure in these patients with urine protein creatinine ratio, those who have been diagnosed at type 2 diabetes mellitus, whereas the patient has not progressed to renal failure. That means renal functions are normal. So the methodology was a cross-sectional study. Study site is Yanagoya Medical College Hospital and study duration is 1 year. The current status of the study is ongoing. So coming to the inclusion criteria, according to ADA criteria, we have included patients with type 2 diabetes mellitus, and they should be having proteinuria measured as per urine protein creatinine ratio, and they should have normal renal parameters according to the lab value. Exclusion criteria were deranged renal function, volume overload assessed by clinical examination, use of diuretics, and urinary tract infections. Statistical analysis, a preliminary analysis of 18 available samples was done. Association between the parameters were assessed using Pearson correlation coefficient, and grouped analysis based on extracellular water to total body water ratio was analyzed using Mann-Whitney U test. So coming to the results in this preliminary study, according to Pearson correlation, there is no specific correlation, whereas in pulse pressure we can see and visually the trend increases as extracellular fluid to total body water ratio increases. Whereas even in urine protein creatinine ratio, there is no specific correlation. And R square is 0 for negative association and 1 for positive association. Here, however, it's more than 0 in all the samples. So in box and scattered plot, we can see that even though it's not statistically significant, the median values were taken in extracellular to total body water ratio, keeping a cutoff of 0.4. So we can see the median value is more in all the patients who had ECF to total body water ratio more, even though it was not statistically significant, probably due to the low sample size. This is the correlation of mean arterial pressure and pulse pressure. Even urine protein creatinine ratio was more, the median was more in the sample size of extracellular water to total body water ratio, even though it was not statistically significant. P-value was 0.4. So coming to the conclusion, we can find that mean arterial pressure, pulse pressure, and urine protein creatinine ratio tends to be more in patients with extracellular fluid to total body water ratio more than 0.4. Whereas we need to recruit more samples in order to analyze the most sensitive and specific biomarker to raise the to indicate the raise in ECF to TBW ratio to improve the significance. Coming to the discussion, we know that body fluid balance is tightly regulated in our body, whereas in end-stage nephropathy, the body fluid balance is severely altered. We can see it as edema because there is an extracellular fluid overload. So in this study, we want to prove that body fluid balance is altered initially, even when there is renal failure has not set in. So we have used here bioelectrical impedance because traditional methods require use of tritium oxide and Evans blue, etc. And it's a time consuming and cumbersome method to estimate. So this bioelectrical impedance just takes 2 to 3 minutes to assess the fluid volumes. So early changes in volume is one of the factors that can lead to progress of end-stage renal disease and reduced kidney functions. So there is a clinical value for intervention, and we can prevent progression to end-stage renal disease by controlling the ECF to TBW ratio. These are my references. Thank you.
So it is definitely a novel concept that you have tried to look into.
Yes.
Even the title is beyond our comprehension for most of us who are actually, so you've gone into a research in this topic. Hats off to you. Okay.
Thank you, sir.
So now I wanted to understand, you assessed total body weight and extracellular fluid by a impedance.
Yes, sir. Bioelectrical
Bioelectrical
analysis.
impedance. Can you please elaborate on this for the knowledge of all of us on why, how, and how it is done?
So bioelectrical impedance, basically the electrodes are placed in the palm of our hands and the feet, and an electric current is passed, and in that we can analyze the skeletal lean muscle mass, body fat, the total body water, extracellular fluid, and intracellular fluid volumes as per the difference of the electrical values.
Okay. How accurate is this?
Sir, it's around 70% sensitive and 90% specific.
Okay.
Sir, in body 520 is the model that we have used in our college. Yes, sir.
Is this accepted internationally, or do we have similar standards of these machines?
Yes, sir, there is.
It is?
Yes, sir.
Okay, good. Now, the patients who are included in the study you said was how many patients?
Sir, 18 as of now.
18
Preliminary
patients.
study. Yes, sir.
It's an ongoing study.
Yes, sir.
What was the cutoff for your proteinuria?
Proteinuria, urine protein creat ratio was the one that was taken. So according to our lab, 0.2, more than 0.2. Urine protein creat ratio.
So 0.3, no? 300 micrograms.
Yes, sir. According to the our lab calibration, it was 0.2. The calculation came up to.
The accepted standards that
Yes,
are
sir.
there. 300.
More than 300, yes, sir.
30 to 300 micrograms is
Yes,
what
sir.
is the criteria, right?
Yes, sir.
Now, the other point that you wanted to measure in this was, how does this have an impact on progression of renal disease? How it can have a predictor for renal disease?
Sir, there have been studies showing that the more extracellular fluid overload is there will be decreased perfusion to the organs. So that can be told as an independent risk factor for progression of renal disease. So if we can alter reduce the ECF before it is clinically seen,
So
whether it is possible to prevent the progression.
Is this a one-point study that you do? Is that measurement taken as one single point parameter?
Sir, which one, sir?
The body,
Well,
total
yes,
body
sir.
weight.
Yes, sir. 1 point.
Wouldn't you think that there are so many other parameters that would alter this total body weight and ECF in a given individual at given different points of the day based on the fluid intake of an individual, whether the person has had an exercise, not an exercise? So do you think that all these parameters are all
Sir, according
confounding?
to the criteria for measurement for the body composition, we have to take the patient early morning on empty stomach after urinating to prevent any changes throughout the day.
Was this the criteria that you had used?
Yes, sir. It's there as per the body composition, this thing to measure that this is what to be done for the accurate bioelectrical impedance.
Were other causes of hypoalbuminemia excluded, like cirrhosis and things like that?
Yes, sir.
Nutrition and all that?
So nutrition we hadn't looked into, but we have avoided all cirrhosis and this thing. Clinical examination and basic history was taken, and all those were avoided.
Clinical examination is not a criteria for cirrhosis.
No, sir.
You mu-
Cirrhosis patients we
you
have
must
not
have a
taken, sir.
fibroscan and albumin.
Yes, sir.
Okay, okay. So, what was the objective when you set out to do this? What is your end goal in this?
Sir, that using that if we can decrease the extracellular fluid load before the creatinine worsens, like whether we can prevent the patients to going into the end stage, that is progression of renal disease, and we can prevent hemodialysis and other complications in them. And no, sir. Yes, sir. And sir, even this early atherosclerosis and increased cardiovascular mortality is also mentioned in one other study which was done. So even that we can bring down or not is another one of the factor.
I think Sydney sir's students, sir, can you put a little bit more information into the people here to how and what it is?
This is a pretty novel. I was a reviewer from journals. Some idea I got from that. So I thought this is a novel idea, which probably is the early predictor of any vascular changes. And that's why I said, why don't you look at this? And with this difference in this ratio, we see this patient having pulse pressure which is going up. So this must be having an impact on the pulse pressure, which ultimately could be a cardiovascular risk factor for all the patients with type 2 diabetes. That was the reason.
Water intake and water excretion. It's a day in and out phenomenon. It varies on all the hours of the day. And would it be imperative that like if you could have done at multiple levels?
True. This study needs to be really looked into more carefully, and we just started it. See, it should be, this is exactly what research is all about. Can we do it in our setup? One thing. We can't, look for a sky for our thing. And secondly, is it something novel which we can apply to our population? I think these are the two things if we look into, I think good research will come out. And it's the last moment I told her, why don't you present this also? So that she's still ongoing, and that COVID had really created a lot of problems. So a lot of things. I appreciate her because this is a difficult topic, but she still did that. I didn't want to, there's absolutely no influence to your marking, absolutely no. Because you asked me to do it, I am telling you.
What is this? Sydney, what is this instrument?
That's the instrument, she will be able to tell better.
Sir, it is basically we have to stand on the instrument. Sir, around this.
No, you should
little more. Yes.
No.
Yes, sir.
Also nowadays to assess the body fat.
Yeah, that is there. That is body composition analysis.
The same parameter only. We have two metal things which checks the impedance.
Yes.
Just to add on, sir, this instrument is called a body composition analyzer. The nutrition departments usually have this. So what all they look into that analysis, the principle what she told is right. It's based on the bioelectrical impedance it measures. In that report, what they give is along with the weight, a calculation of BMI, waist hip ratio, segmental muscle mass distribution, segmental fat mass, extracellular fluid volume. So all that analysis is a comprehensive. It's a body composition analyzer that she has used. In that, one of the indices that she has used is the extracellular fluid to the total body weight.
So this is a routine machine that every one of us use in the clinics, which is a body
Yeah.
composition analyzer. But when she talked about using electrodes and other things, so that is not there part of your regular machine. It does not have any of those things.
It's a handheld.
No, sole in the hand also.
Thank you, sir.
Okay, so the last paper, Dr. Siddharth Sadnani. Could you come over, please? Yeah.
Good morning, everybody. So I'm Dr. Siddharth from KMC Manipal. I'm a final year resident in internal medicine. So this study I will be presenting is to look at the prevalence of metabolic syndrome in heart failure preserved ejection fraction patient using an H2FF score in a tertiary care hospital in South India. My guide was Dr. Raviraj Acharya, the HOD there, and MM Prabhu sir also had inputs on this. So coming to the introduction, background about heart failure, the prevalence is around, some studies say up to 5%, 1 to 5%. Subclassification is based on EF with HFpEF being when it's more than equal to 50%. And they have different pathogenic mechanisms, and the treatment varies quite a bit. So it's important to know which subclassification a patient falls under. So the major differences are, and HFpEF patients have older age, and they have the therapeutic, there's no very good treatment available even today, even after the Emperor Preserved trial. So some background. So HFpEF is a complex heterogeneous syndrome. It accounts for up to 50% of all heart failure, which is sizable. And the ERIC study showed that it is up to 70% in elderly people, even up to 77. The three words I'll mention here: a multimorbid patient having a lot of inflammation, causing coronary microvascular dysfunction. So those are the three main things, and then the patient has HFpEF. So in India, the Trivandrum Heart Failure Registry, which is the biggest authority on heart failure in India, they had like 57 patients who had HFpEF in one of their studies in 2020. But they had major drawbacks in their study, that they included valvular heart disease and also infiltrative disorders, which is not true HFpEF. A new National Heart Failure Registry has been established in India, with Trivandrum leading the way, and all AIIMS and all premier institutions are part of it. Data is still to come out from there. So gaps in knowledge, I'll just highlight the major points. There's no good prevalence data in relation to metabolic syndrome and HFpEF, not just in the Indian context, also in the world context. There's no effective evidence-based treatment due to the aforementioned factors, and it's a complex syndrome, not easy to diagnose it. We overdiagnose it or underdiagnose it. So no study in India has looked at this H2FF score, which I'll be elaborating on quickly. My primary objective was to assess the prevalence in METES in HFpEF patients using this H2FF score. Secondary objectives were epidemiology, risk factor prevalence of HFpEF, correlation between H2FF and NT-proBNP, and using a modified H2FF score with a BMI cutoff of more than equal to 25 in the Indian context, of course, and to analyze data accordingly. So one major thing, all diastolic dysfunction is not heart failure preserved ejection fraction. A major point to be made here. Methodology, the study design was, it was a prospective observational cross-sectional study, single center based from Jan 2022 till November 2022. The sample size was 128 using this statistical formula. I can elaborate on it later if need be. Inclusion criteria was adults more than 18 years of age with a clinical syndrome of heart failure with an EF more than equal to 50%. And this clinical syndrome was defined by Framingham criteria. Exclusion criteria, like all infiltrative disorders, were excluded. Restrictive hypertrophic cardiomyopathy was excluded. Valvular heart diseases were excluded, as were primary pericardial diseases and primary pulmonary vascular diseases. This is the modified Framingham criteria, where 2 major or 1 major plus 2 minor is diagnostic. Coming to the H2FF score, this is a score which came out from the Mayo Clinic in end of 2018-2019. So this is to help us diagnose HFpEF a little better. It's a very simple score based on 3 clinical parameters and 2 echo parameters. The clinical parameters are, heavy, being BMI more than 30, carrying 2 points, AF, which can be clinically or ECG-wise diagnosed, like a combination of both actually. So 3, that's the highest points that any variable carries. And pH is like 35 PSP, more than 35, and filling pressure of the E by E prime, which Sir had earlier, the first study mentioned, I'll be elaborating on that very quickly. More than 9. And elderly, more than 60 years of age, hypertensive on 2 or more antihypertensive drugs. We use the modified H2FF score also to analyze and compare the data with. So based on this, you get a score from 0 to 9. 0 and 1 HFpEF is ruled out, 6 to 9 HFpEF is ruled in. 2 to 5 is where a lot of population lies, and for that we used NT-proBNP to further subclassify them as having HFpEF or not having HFpEF. So exposure assessment was the metabolic syndrome. We use the IDF criteria, which central obesity is the core of it. If you have that, then you look at 2 more, so 3 out of 5 is diagnostic of METES. And 90 and 80 are the cutoffs in males and females in South Asians. Waist circumference was measured standardized way, top of the right iliac crest in a horizontal plane. Echo, this is like the pulse wave echo which is used, which is majorly even followed today. But it misses out on a subset of HFpEF patients, early HFpEF patients and the moderate dysfunction pseudo-normal phase, where the E by A is more than 1, which is similar to a normal patient. So the E by E prime picks up that also, and E by E, the E prime is actually is a very sensitive measure. So this is a tissue Doppler imaging, which quickly. So we actually measure it, you gate it around in the interventricular septum, where the mitral valve anterior annulus is there, anterior leaflet, and you calculate the negative wave, which is the relaxation of the septal annulus. So this was a study flow. 128 patients were there, and then using the metabolic syndrome, this was how the statistical analysis was done. So 71 patients had METES, and 57 patients did not have METES in the HFpEF population. Statistical analysis was used, standard methods were used. I can elaborate if time permits later. The results of the study. So demographics, more than 60%, we can see like 61 to 70 and more than 70. More than 60% of patients were elderly. The gender of the patients, 59% were males and 41 were females, which is different from a lot of studies. Clinical features, breathlessness was very common, as was bilateral Krebs. NYHA 4 was the most common NYHA class seen in our patients, and we see filling pressure was seen in more than 120 patients. Almost all the patients had it. Comorbidities, 77% had hypertension, and IHD was sizable in our population, 70%, around close to 70, and type 2 diabetes, 51%. Using the HFpEF score, we had like 101 patients with the classical HFpEF score who had this, had HFpEF, and 105 using the modified HFpEF score. The mean of these variables was like age was 62, BMI was 29, other variables like NT-proBNP was around 3,900. So did we get where we wanted to get? A small step, giant leap, didn't happen. So 55% of patients had metabolic syndrome in our population. Female sex was more prevalent in HFpEF patients, and it was statistically significant. Hypertensive, diabetes, BMI were also statistically significant, more in the metabolic syndrome group in HFpEF patients. So the distribution of weak positive correlation was there with NT-proBNP level and HFpEF scores also. And HFpEF high probability score meant that you have more probability of getting metabolic syndrome. So to conclude our study, metabolic syndrome was more prevalent in patients with HFpEF. Female gender, higher BMI, hypertension, and type 2 diabetes was significant. H2FF score and modified H2FF scores positively correlated with NT-proBNP levels. High probability of H2FF score was associated with presence of metabolic syndrome. The discussion of my study, we looked at, like, this was a study Ganpati et al. Which from Trivandrum.
I think we'll summarize.
Yes, sir. So IHDs, like, there were some differences. There's no direct correlative comparative study presently there, even abroad, which has looked at these parameters together. So that was one thing. Strength and limitations of the study I will just highlight on. So the limitations were small sample size, so generalizability, external validity would not be there. Cross-sectional study, causation not possible. Observer bias, echo measurements cannot be ruled out. Selection bias may be present as less females with HFpEF in our study. Tertiary care center and more CAD patients may explain this in our study. Missing some data on NT-proBNP and lipid profile, but we did data imputation, and there was no problem with that. So first study to our knowledge in India to use H2FF scores as a means to diagnose HFpEF, proven to be sensitive, specific, as well as predictive of prognosis. Exclusion criteria were designed to select actual HFpEF patients, not all diastolic dysfunction. There was no loss to follow-up. Data, majority of it correlates with other studies. No random misclassification of outcome or exposure, and a modified H2FF score is put forth. These were my references. Thank you.
failure with preserve H2FF.
Yes, sir.
You said it is more than 30.
My criteria, sir?
Yeah, the H2FF
H2FF score, sir?
was more than 30 for heavy.
In the criteria? Yes, sir. More than 30, yeah. The BMI more than 30.
But that is not acceptable in India.
Yeah, so I used a modified H2FF score. I calculated that all data was computed based on the actual H2FF score and the modified H2FF score, where the BMI cutoff was used was 25, sir. Okay. So we analyzed data, and all the data, all tables that were produced were both the H2FF as well as the modified H2FF scores.
So you said this is the first study that is being conducted in India using
the H2FF score, even right now, presently, sir. Yes.
Okay. Okay.
It just concluded study, sir.
And what was the correlation between the NT-proBNP and the score?
It was a weak positive correlation of 0.24, sir.
Okay.
Yes, sir. Yes.
Okay. And you also mentioned that in the METs
Yes, sir.
components, which was the one that was the highest contributor to this? Was there any sub-analysis?
Yes, sir. There were like hypertension and waist circumference were the highest predictors in the METs components, sir. These two were more predictive than diabetes and other parameters.
Waist circumference and?
Waist circumference and hypertension, sir. The presence of hypertension.
Yeah, so the various criteria, can you just run through that slide, that modified FPF score?
Yes, sir.
Yeah. Go back.
The score, do you want to look at
Yeah,
the score,
yeah.
sir? Okay, sorry, sir. This is the score, sir.
Okay. It is a good study, Dr. Siddharth. Nevertheless, you lost out on time. It was probably a lot of data that was there in it. Your presentation was also good. What's your take? What's your recommendation going forward?
My recommendations are metabolic syndrome. Like, I think one of the main things that people don't do studies with metabolic syndrome is, like yesterday somebody was mentioning, no one wants to carry a measuring tape. I needed to do that for all my patients. So there's less data on it. So I think metabolic syndrome is a risk factor for heart failure, preserved ejection fraction. We need to acknowledge that, and further better studies need to be done looking at that, because at core of HFpEF and metabolic syndrome is inflammation, and that leading to coronary microvascular dysfunction leading to this. So if you understand it better, we can look at better therapeutic targets, as we have no proven treatment for HFpEF even today. Even empagliflozin is, if you do look at the composite endpoint, it was mainly to do with hospitalization than with mortality. So we don't have definitive good treatment. So we need better treatment for HFpEF patients who are actually 50% of heart failure and are actually, mortality is also comparable to HFrEF. So we need better therapeutic targets. So metabolic syndrome can be looked at it also, and a good score to diagnose HFpEF better, sir. Two important takeaways for my thing, and later on therapeutic step. So a very, very small step maybe in the right direction.
And on a lighter note,
yes, sir.
What you are saying is quite frightening.
Yes.
In this room, except for Srinath and Sydney, I don't think anybody else fulfill this criteria.
Yes, sir.
My question would be, if the cardiologist is sitting and doing an echo, either we have referred them or the patient has themselves gone.
Yes, sir.
So, do they mention this score anywhere?
They are also presently, after I did the study, one of the cardio registrars in my college, my institution, is looking at doing a study using this, and there is another score which the ESC has come out with, which is called the heart failure HFA PAF score. So they also, one of these scores is actually recommended by presently in all diagnostic algorithms by even JACC, ACC, as well as ESC.
Okay. So the next time, I think my takeaway from this would be that we should suggest cardiologists to do this score.
Yes, sir.
in
And they
all the
should
patients.
more importantly, sir, you need to suggest them to actually first of all start doing E by E
They are
prime.
cardiologists, they'll not listen to anybody. It's very difficult to convince them. It's not that easy as you say in a research
But
thing.
E by E
Either
prime
ways.
is like E prime is the most difficult thing that I found. A lot of people are not calculating that also.
Okay,
So this
thank you.
Thank you,
I
sir.
think we'll wind up.
Another small comment, lighter note.
Yes,
Whenever you say HFPEF, I feel huff puff. Huff puff while walking. So, so that correlates with your study, I think.
There was one joke which was going around that nowadays there's a lot of talk about mental health. So just try walking 4 stairs. You'll forget your mental health because you'll be so much breathless.
Yes.
So that is very important.
Thanks a lot, sir. Thank you, sir.
Congratulations, Doc. Let's have a huge round of applause for all the members who have presented today's presentation today, and also for all the members who are there in the audience today, which shows a humongous interest in the clinical research aspect that we have. So as Dr. Sydney has been pointing out, one of the core objectives of a conference of this nature, and especially the RSSDI, is to promote this concept of research amongst young scientists like y'all. And if this is taken on a day-to-day basis, I mean, we do not have to, as Dr. Sydney said, it's not the absence of grant or the resources that are available. The amount of patients that each one of us see in our chambers is humongous clinical material. And if we are able to harness our resources properly and they are able to curate the right kind of a research material, we will do human service to our public and have immense amount of recommendations. We will stop quoting ADA references, EASD references, criterias, and those kind of stuff. Those guidelines are not meant for us. Our patients are different, we are made differently, and we need to have our own criterias, and we need to have our own guidelines to make sure that we are able to promote this. And how do we get out of this? It's with such clinical research like this. So a huge round of applause to each one of you. Please carry on this momentum. We encourage more and more people to take up this in a very passionate manner, and we will always be there to support you all in all your initiatives. And RSSDI has taken it in its major mandate that it will support all the required grants right from the state to the national chapter. So huge applause to each one of you, and closing remarks from our senior consultant, Dr. Sydney.
Thank you, and one or two reflections. Before I do any of those things, I want all of you to give a loud applause to our judges. They were so critical, very, very focused, and the comments were very much required. And this is exactly what they have done. They have done the job so beautifully well. I was very much, if I were a student there wanting to present that, I would have refused to go to the dais and presented it. Because that criticism was very, very much, very critical. And this is exactly what you require to. Don't get worried about the criticism, that is required. Number two, you don't need big things to do research. All that you require to ask a simple question, what is it, something different? Has it been done in the past? If it is done in the past, what is the gaps that you are going to look at it? If you do that, I think any research paper will come. And there are enough and more people who will be prepared to help you out. And today's presentation, each one of you have done so well. I am really proud of all of you. It doesn't matter whether you get a prize or not. It is simple. See, I had a student of mine who was a little eccentric fellow. He wouldn't come to the class, he wouldn't do nothing. If you ask him after the class, did you understand anything? He said no. In front of you, he'll say no. And the worst part is, just before examination comes, so I don't want to appear for examination. I said, why? Whatever you people teach is all wrong. I said, see, we have a human brain. Your brain is a little beyond us. It's an Einstein brain. So you are not fit for this. You should be a researcher. Because he refuted the Newton's law also. In physics, I said, heart and Newton's law doesn't go together. This is what he told me. I thought this fellow is nut. So I said, see, even if you want to become a researcher, if you don't have a basic degree, nobody will accept you. So finished. He said, yes, I will do it. He passed also. Thereafter, he never did his internship. He was in the IIT, sitting with them. After 1 year, he comes back. So I want to do a project with you. I said, do it. He did. Why people with diabetes don't get gangrene? They stand. All of us stand. Do we get gangrene? We don't get. He said, why only diabetics get gangrene? So he said, I'm proposing a different theory. So he started with his own theory. And he said, because this is known as chaos theory. This chaos theory, he says, when we stand, we go on shaking. So the foot pressures keep changing because of our nervous system, the autonomic nervous system. But in a diabetic, because it fails, the pressure becomes static. And that is why you get so much of pressure. And we will try to prove this. I said, I'll give you my patients. I got enough and more of them, I'll give you. Those are the 1990s, not now. Even mobiles were not available. So he had to make a stand of glass. And who would stand on a stand of glass? A patient would never stand. But he saw to that it was very sturdy, and he bought a video camera and put it under and shows how the whole thing changes in a normal person and patient with diabetic neuropathy. So beautiful, and it got published in a best of journal, the Science, and also he got the first prize by DST. What do you know what DST is? Department of Science and Technology, gold medal. He came and showed me. I said, this is for you. I said, no, no, this is for you. This is technology. This is the brain. Now I don't find him. I don't know where he is. I must go in search of this boy. But that is exactly what research is all about. Just things, a simple thing. Thereafter he goes after it and gets it done. And this is exactly what I want these young people. We couldn't do it, so that's why I want to promote this to you people. You start doing it. Thank you very much.
Thanks for the encouraging words, sir. And I should say, sir has convinced his institution to give a cash prize of 10,000 rupees for the best paper of this conference. So that will be announced a little later. So another 3 people have requested for presentation. For the interest of time, we couldn't accommodate them. So anyway, they have been given a chance to present it as a poster. And with this, we'll wind up this presentation session. There is a presidential oration going on in the main hall. That we will do it after the oration. Oration, yes, yeah. Okay, so we should be there for the presidential oration. Please, kindly. So there is a talk about the biostatistics, yeah. So we'll come back, and so that would be a very interesting and important session too. The statistics is very important. So after the presidential oration, please, most of the researchers, scientists, students, please come back.
What you feel when your feet hit the pavement. Keep on reaching, hold on to what you believe in. Don't gotta learn what they're teaching, no, no, don't believe what they're preaching. Remember the meaning, this old folk song we be singing. I'ma raise my arms high, I'ma touch the skyline.
Before you hit the skip button, I can get your car insurance quote.
Whenever I used to pass by people, मैं यही सोचता था यार कि why can't everyone smell beautiful? And that's exactly when I turned my passion.
once again, welcome back to Hall B. And without much wasting time, I slide again. I welcome Dr. Madhu, who is a professor, Department of Community Medicine, JSS Medical College, and Deputy Dean for Research for JSS. And please welcome. This is a talk about basic statistics. So it's a very important thing for the young researchers to be aware of the statistics and how we can. So most of the research is based on statistics only. If the statistics is robust and we understand how to bend it to our use, not convenience, so it will be much more, we can generate much more data and much more research papers. Thank you, ma'am. Please come.
A warm good morning, and I bring greetings from JSS Medical College and JSS Academy of Higher Education and Research, Mysore. I thank the organizers for giving me this opportunity to share about my few thoughts on the basic biostatistics for clinicians. This is a 2-year course which we offer at JSS Academy of Higher Education for in the name of MSc Medical Statistics with 20 minutes that you are time given. I will try to do justice, giving a bird's eye view of the topic. At the end of this session, I hope all the delegates will be able to identify various data and the statistical variables, differentiate between descriptive statistics and inferential statistics, try to understand the different types of graphical presentation of the data, and understand the availability of various statistical software for data utilization. And most important, clinicians develop statistical thinking in their clinical practice. To begin with, I would like to ask these questions. As a clinician or as a practitioner, what questions do you encounter in your day-to-day clinical care? Suppose if you are seeing a case of fever, which disease will be your first clinical diagnosis? Would you think of malaria or dengue? Okay, if it's somebody from the coastal Karnataka, they would think malaria. But if I'm seeing the same patient in Mysore, my first will be dengue, because as per my knowledge, I use the knowledge of prevalence that over the past 3-4 years, I have not heard of any malaria cases in Mysore. So that would be. So here I start using the proportion or prevalence, the simple statistics in my clinical care. Next, every year I encounter episodes of asthmatic attacks in my allergic bronchitis patients. So I want to know, did this episode increase this year, or was it the same, or did it improvise, or it increased? So I would like to know what was the incidence of these episodes of asthmatic attacks in my patients. So again, these are numbers. How many of my diabetic patients have complications? So maybe I'm treating around 100 patients per month. In that, how many of them are having complications? How many of them are not having complications? How is my care being delivered to them? Again, it's proportion and percentages. Or you have tried a new combination of therapy for 2 groups of your patients. For one, you would have asked them to take only medications. For another group, you would have asked them to take oral medications, along with them asked them to do yoga. After some time, you see there is a difference in the blood glucose in these patients. Now you want to interpret that. How do I interpret my observation? So the answer would be compare the mean glucose between 2 groups and apply a simple statistic test. So wherever our clinical care and observations are coming, the use of these numbers in the form of percentages or means is a way to give scientific value to it, or what we call as giving evidence-based clinical medicine. So this is our day-to-day life, and with simple proportion or percentages and simple mean calculation, we start our statistical analysis. This was one study sponsored by ICMR for one of my students. So first step, what she did was she just took out the percentages of the 970 students whom she had done the study on. Simple basic statistics, calculation of percentage. With this, it was only describing the study population. Further, what she did was she looked into what was the gender-wise, male and female-wise exercise pattern that was happening in these 970 students. So here, male, female, she has observed some percentages. So similarly, she looked into the course-wise, MBBS, BDS, pharmacy, engineering, and commerce, and took out the physical activity parameters, like sedentary to 5 times a week. Now she had to derive some value from this percentages. So what was done? A chi-square test was applied. She found out the p-value, and with evidence now she can say that the proportion of females led a sedentary lifestyle. That was almost about 58%, whereas the proportion of males, that 12.9%, or more than say around 50%, at least do 3 times a week of physical activity. So this becomes an evidence with scientific content being justified. So similarly, here the next way, in another study where around 8,000 school-going children were analyzed and looked into what is the proportion of malnutrition, overweight, and normal BMI they have. Somebody told me one picture speaks 1,000 words. In the previous two, it was tables, figures, and only numbers. It could not attract the attention of my audience. So in this, if you see in one picture, locality-wise, male, female, numbers, percentage, everything is depicted. It's easy for me to convey the kind of study subject that was there in this study. Similarly, in one figure of this, we have compared the WHO and IAP criteria for BMI. In BMI, they use this percentiles, 3rd percentile, 5th percentile, 50th, 97th, 95th, like that. Anybody less than 3rd percentile is considered undernourished or underweight. More than 90th is considered as overweight. Between this is considered as normal. So we also compared between males and the boys and the girls, and also using the 2 criteria. So graphical presentation is another way of presenting it to the audience or whatever data or research that you have done in a simple way. So all this is nothing but statistics. We just get the fear that I chose medicine because I didn't want maths. But if you see in reality, every day we do apply knowingly or unknowingly the knowledge of mathematics. So statistics starts right from the collection, classification, presentation, analysis, and interpretation of our numerical data into something which we want to infer from. We want to give out a clinical relevance to whatever we have observed. So when you apply these principles into the biology or more so the medical related data, it becomes biostatistics or medical statistics. So to say that it's the key to conduct new clinical research, and it's one of the foundations for evidence-based clinical practice. So how did all this start is, if you see the 18th century and the early 19th century, that was where the germ theory was getting into, evidence was being generated. People did not believe just by whatever somebody said. They wanted something logical to be understood. So he was the person, Pierre Charles Alexander, who introduced this numerical method in medicines. Whatever he did, he gives certain numbers. Simple they started was with proportions, and then simple analysis of calculation of means. So all those things, where to do percentages, where to apply means, is first you have to know what is your type of data, how you want to present it. So broadly we can classify these variables as categorical or numerical. So when I say these were the number of males, these are the number of females, I only name it. Or these are the number of diabetic patients, these are the number of patients who don't have diabetes, who have hypertension, who don't have hypertension. I name them under a group, so it's a nominal data. If I'm able to categorize my patients, those data into like stage 1 hypertension, stage 2, stage 3, and cancer stage 1, stage 2, stage 3, or if there is an order, so I call it as an ordinal data. There will be certain data which I will only be taking it as discrete numbers. For example, how many episodes of hypoglycemic attack my patients had. So it's a discrete count. In 1 year, he would have had 3, or he would have had 5 or 7, or no. So it's a number. So 0, 1, 2, 3, 4, it's discrete. When I want to measure and I want to analyze the fasting blood glucose level, postprandial blood glucose level, HbA1c values, which are like you can get it as 120 fasting, 121, 122, 123, these are continuous. So I categorize them as continuous. If there are an interval which is very much defined between one to the next, we call it as interval. If there is a ratio between the one value to the next value, we call it as ratio. But for all statistical analysis purpose, just remember these two, categorical and numerical, and these nominal, ordinal, discrete, and continuous. For analysis purpose, for simple basic analysis purpose, these data can be categorized into quantitative and qualitative. Quantitative, what I told is the continuous, and qualitative is what you can count. So those are discrete and countable. So these were the examples I gave. So what do we first calculate is mean, the basic statistic. Here if it's qualitative, it is proportion or percentages. If we ourselves collect the data from the patients directly, one-on-one basis, we call it as primary data. But if it is obtained from medical records or already published data from the journals or from other databases, we call it as secondary data. So this entire picture is what is the real statistics. We all are here as researchers because we are interested in this big diabetic population and the various research questions we ask. But it's not practical or possible for anybody to do the study on all the diabetic patients that are there in the world. So we are capable of doing our study on a small sample, could be of 100,000, 10,000, lakh, based on our capacities and the funding we get. So we start everything or whatever we observe is in this small sample. So I told we have only two types of statistics, descriptive and inferential. So descriptive is to simply calculate percentages and means of what research question we have asked. So either you summarize, if you have done your study on 100 patients, you summarize it either into a numerical, percentages or mean, or give a graphical summary of the sample. So most widely used sample descriptive statistic is sample mean and sample proportions. From this, using our inferential statistics, the so-called chi-square test, t-test, many tests are there. So we would be estimating our parameters, which are nothing but what is in reality of the world. So here we will get the population mean and population proportion. So this inferential statistics is like what you have done on a sample. Based on your inferential statistics, it's generalizable to the whole diabetic population. Descriptive statistics starts with only two things, measures of central tendency and measures of dispersions. For ease and simple of understanding, measure of central tendencies, remember that it has got to do something which is at the center. Or if we have done it on 100 subjects, we want to know what is the average. So for calculation of average, these are three ways in which you can calculate the average: mean, median, and mode. Mean is nothing but it is one single figure where you take all the 100 values and divide it by 100. So you get that mean. Whereas median, what it does is, median will distribute this entire observations into two equal parts, 50 that side and 50 this. Whatever value comes in that central will be taken as the median value. So similarly, the mode is out of your 100 patients, how many of them have the most common value? That will be taken as mode. So it depends on the type of data and in what situation you have to use. Commonly in statistics, we use mean 80% of the times. Sometimes in 20% of the situations, we will use median. So I just gave an example here. You would be interested to know what is the mean HbA1c value of my 100 patients who are on a particular antidiabetic combination. Somewhere if it comes 6.8, probably you have calculated a mean. So I told descriptive statistics, the other part is the measures of dispersion. So what does that dispersion mean? So we have calculated one central value. But what about the other 99 people's values? How is it varying from that central is what dispersion says. So three common measures of dispersions widely used in applications are range, interquartile range and standard deviation. To understand the range, it is nothing but what is the maximum value and what is the minimum value for those 100 patients that we have looked into. If you take the interquartile range for the same 100 observations, if I divide it into 4 equal parts, it will become a quartile. The Q2 is the median one. So 50% are this side, 50% are that side. So I can call it as median, Q2 as median. Yeah, okay. So whatever is at this Q1, we call it as first quartile, and what Q3 and above is called as third quartile. So if you see, majority of our observations, nearly 50% of our observations will be around this median and between these interquartile range. Now if you take the standard deviation, always they'll say mean plus or minus standard deviation. What is that? So you have calculated a mean. When you say one step plus or minus some value of one standard deviation, it means that 34.1% of the observations or values are on the right side, 34.1% of the values are on this side. So within 68% of the values will be around that particular mean. So this is the descriptive statistics. What is the message that you have to remember here is, when you are applying statistics for any of your analysis, if you use mean, use the dispersion plus or minus standard deviation and represent it like this. If you are using median, use interquartile range and represent it like this. Always biostatistics goes with epidemiology, or epidemiology and biostatistics are linked together. So if you have understood the epidemiological study designs, there are certain basic questions, and you would have seen this right from undergraduate level. So what is that you have to get inference from this and link it to biostatistics is it I'm describing one study group, or am I analyzing and comparing two groups? If you are using only one group, like for example a case report or a series of patients of a particular type you are just describing, or you are describing a particular disease condition with respect to time, place and person. So it's usually a one group, and most of the time it's one group where percentages are more commonly used. If you are comparing, so it's an analytical type of study design. Either you are observing something or you are intervening something. If you are observing, in a cross-sectional study, you have one time you go, you observe them and you make them into two groups, those who have complications and those who don't have complications. Whereas in a case control, you have again two groups. First, you will identify a particular group of patients who have a certain condition. Similarly, you will take an age and sex matched control. Whereas in a cohort, you have two groups of people who are exposed to a certain risk factor, who are not exposed, where you will follow them up over a time period. So these are two groups again. Obviously, in experimental study, we have one which is a control and another an intervention. So all analysis with these type of studies will have two groups majoritarily. Here it will be single group unless specified. So after knowing that, this is where our inferential statistics starts. So tests of significance, what we call, either it should be a parametric or a non-parametric. How do we determine if it's parametric or not? That is determined by the normal distribution of the data that you have calculated. It's not rocket science to know, okay, whether it's normally distributed or not. I told only two things that we have to remember is mean, percentages. So for normal distribution, look at the mean and standard deviation. If your standard deviation is higher than the mean value, then it's a non-normal or it's not normally distribution. Your standard deviation should always be less than the mean value. So make a choice whether it's parametric or non-parametric based on the normal distribution. then remember this simple slide. Okay, now I have my samples. Maybe I've collected 50-50, 80-80, 100-100, 90-90. Ask the question whether it's normal or not normal. Look into the mean and standard deviation. If your standard deviation is very much less than the mean value, yes, it's normal. If it's not normal. Then what is this paired, unpaired is another question. Paired means if you repeat it in the same group. Like for example, before giving a new treatment and after giving the treatment, what happens to the blood glucose value? On the same group of people, you are measuring the blood glucose before and after. So we call those groups as paired. If it is different, like I have one group who is on one type of medication, another group who are on another type of medication. There are two different medications I am looking for. So then it is unpaired. If it is two group, it is t-test. If it is more than two groups or three and more above, it is ANOVA. Similarly, here also t-test and ANOVA. Whereas if it's not normally distributed, there are names for it. The name is not important. What is the science behind using that particular test is important. So if it's two groups and if it's paired, Wilcoxon sign rank test. Can it take some more time? 5 minutes? Okay. If it's more than that, it is Friedman test, and unpaired Kruskal-Wallis test. Just to remember, it's not going to make huge difference if this is changed, this is changed. Only the p-value and the kind of interpretation that you get or the background in which this analysis has been developed will be varying. Another common thing which we do in our research studies is finding the relationship between variables. So in that, when we are doing the relationship between variables, first we have to know what is an dependent or an independent variable. So I've taken an example here is, I want to know what is the effect of X on Y. So X is the lipid lowering drug and Y is the individual cholesterol level. So Y is equal to x1 plus x2 plus x3 plus x4. It's a regression analysis equation. For simple understanding, the cholesterol level depends one on the lipid lowering drug the patient is put on. It also depends on many other factors. The duration of diabetes, whether it's a male or a female, the age of the patient, other coexisting morbidities and so on and so forth. So understand that when we are looking into relationship like that, the same data has to be looked in the form of dependent variable and independent variable. So anything you start when you have to look into a relationship, first look, are they correlating? So what is this correlating? One example you would like to give here is, so you want to look into the dose of the drug and the cholesterol level. I take the dose of the drug on the x-axis and the cholesterol level on the y-axis. As the dose increases, does the cholesterol level increase or decrease? What is that I want to see? If it increases and the cholesterol level comes down, it's a strong negative correlation. And another way, the number of hours of walking. I'm walking every day 3 to 1 hour, 2 hour, 3 hour, like that I'm increasing. My cholesterol level is getting reduced. So it's a inverse. So that is what will be told by the correlations. So after this correlation, you can have various types, like if your value of correlation coefficient that is calculated is 0.7 and above, we call it a strong positive. If it is less than 0.2, it is called weak positive correlation. How do we determine if it's positive or negative is the sign. If it is value is plus and above, it is positive. If it is minus, it is negative correlation. Then if it is perfectly zero, somewhere or nearing to zero, that is no correlation. A perfect positive correlation is +1. A perfect negative correlation is -1. After looking into the correlation, we go into this regression analysis. I told you the cholesterol level is not mattering only on the drug he takes. It depends on the various other factors, because human beings are not only one parameter. They are a combination of various other variables and parameters. So we calculate this regression line or an equation which comes, which says that if, for example, in this they are looking into the percentage fat based on the BMI, but you can add other components also, like the type of drug they are taking, the dosage, the duration, all those will matter in analyzing the regression. So regression analysis, I can say it's a multivariate, more advanced, and you can get better interpretation of the relationship between the variables. After analyzing the relationship between variables, the next common where you would like to look into is with respect to time. This survival analysis started with what is the average time a person lives from birth. But now with the application to the patient care, it can be used widely used in cancer treatment. Like after treatment of cancer is started till the time of death, what is the time? But we can use it to other conditions. Like for example, time of detection of diabetes to development of complications if you are following your patients over a period of time. Or time of HIV diagnosis to developments of the full-blown AIDS condition. Or from the time of admission to hospital for a particular condition and how much time they take to discharge. So these are all under survival analysis, though the name is survival because it started with looking into how long people will live. But it can be applied to this based on the principle. The analysis that goes in the survival analysis is the Kaplan-Meier analysis. It's simple to understand that what's the probability of these number of patients over a time period of follow-up, how many will stay along and how many will drop out from that follow-up period. To summarize, we saw descriptive statistics, inferential statistics. Descriptive statistics, measures of central tendency, mean, median. Measures of dispersion or how our data is spread, range, standard deviation, interquartile range. You also saw inferential statistics if it's 2 groups or 3 groups, simple, Z-test, ANOVA, T-test, chi-square, Mann-Whitney-U test on the non-parametric side. In multivariate, correlation, regression and survival analysis. But most important question all the PGs or anybody would look is what is the p-value, what is the p-value, right? But how much importance should we give for that? Look at this example. A postgraduate was very much enthusiastic because they were looking on a new drug. They tried it on 500 patients. It was a new antipyretic. What they observed is, okay, this is the mean, this is the standard deviation. I've got the p-value. P-value is less than 0.05, very excited. The guide asked, okay, yes, there is a reduction in temperature. But is it really making clinical relevance? The decrease was only 0.63 degrees centigrade. So always, even though you get a p-value, look into the clinical implications of that interpretation. These are only numbers. Statistics, softwares, or statisticians will be only looking into the numbers and analyzing your data. It is who you have to give that meaning for that clinical relevance that is having from your data. Another common thing which we encounter in our practice is we are dependent on certain screening tests, we are dependent on point of care tests. But every time there's a question, what is the quality of these tests? How valid are they? Based on those, can we make a clinical decisions? Every time you bring in something new, that's the question. How do we answer for this? So widely used analysis is sensitivity and specificity. So to just why the sensitivity and specificity, or what is the background in which how it is calculated is, we have 2 groups of people who have a disease or a condition, who don't have a disease or who don't have that condition. When we do this test in them, out of those who are diseased, whoever comes the positive, we call them as true positive, and if we calculate that percentage, it becomes sensitive. And similarly, among those who don't have the disease, and when we apply this new test or a point of care test, how many of them are truly showing that they don't have the disease becomes the true negative, and that's the specificity. But more important, what we also have to look is this predictive value of a positive test. What do I mean by that? If I am doing a point of care test, if I am doing a screening test, what is the probability that it is going to say how many of them are truly having the disease? So if you see that, out of my total test positives, that is A and B, how many of them are truly having the disease? So along with that sensitivity, specificity, calculation of predictive value of a positive test is very important when you want to clinically say that yes, this test can be used as a screening test or as a point of care test before they come to the hospital. The next question, we are always encountering with biochemical cutoffs. How did they derive this? Is this okay for our population? Is it right or is it wrong? So this is based on, again, of the same principle. True positives, true negatives. This graph I've just tried to explain. Our lab values, if you just put it on this range, we can categorize them into normal range, abnormal range, and this is one small area where we have to draw the cutoff. How is that based? This is the healthy population or people who don't have that particular condition, who are true negatives, means they don't have that condition. These are a group of values of diseased patients. For that particular biochemical value, they are known as true positive. Identifying this point, where you have minimal false negatives, minimal false positive, is where the cutoff value is developed. So there, for that lab value, you start looking into the clinical relevance or the measures, how it's being, or the clinical presentations are happening. So for this, they do this ROC curve analysis, like for various cutoffs, how are we getting the true positives and the true negatives?
Sorry, ma'am. With the interest of time,
Yes,
can
sir.
you wind up? I feel like my dad is taking me away from my ice cream shop. Your presentation was so good, but with the interest of time, yeah.
The last part, sir. 2 minutes. Yeah. So the last part is the graphical representation of data. Picture speaks more than the words. So these are what you all have been known about: bar diagram, histogram, pie chart, comparative. But what I want to show is there are softwares available like Tableau, JMP software, Python, where you can customize your own data sets and you can give visual analytics like this. Very easily in one slide you can give the entire type of descriptive analysis you want to picturize. Similarly, which has been done for patient satisfaction dashboard. You can develop it for the patient care, the department-wise, specialty-wise, occupancy-wise. The Python, where you write simple codes, you can look into the data visualization. And if you look at this, it's so robust. Different kinds of analysis and interpretation to make even the simplest, smallest data very meaningful and visually appealing for the audience. So there are softwares which are available which will help you to do that. JMP is one such software which gives you the entire spectrum. We are proud to have that JSS has this facility. All kind of advanced analysis for every patient data will be utilized, and it will also analyze the text also and the huge time series data over months or years that of a particular patient also. So lastly, yes, evidence-based practice is important. It emphasizes on the systematic collection of data and the generating of evidence. It is important for the critique of scientific literature. It helps in comprehensive care of any disease. It helps in identifying risk factors of disease and health events. So it will help you to identify the efficacy of a drug or combination of treatment, interpreting your screening test, identifying new clinical syndromes. Last I want to say is, whatever I've presented is just a tip of the iceberg. Statistics is huge. It's only that you have to develop an interest and you can start analyzing looking into all the angles how the data or the clinical evidence can be generated. I thank the organizers for giving me this.
Thank you, ma'am. Thank you. Any comments from Sydney, sir? Anything, sir?
She put the whole thing in perspective, I think simplified very nicely. But one thing, some brains don't accept mathematics. That's exactly what statistics is all about. For some people it looks very simple, for others it just doesn't go in. So, I know. I think after my 10th standard I threw all my mathematics books out. Yeah. End of it, everything looks beautiful. I know. To go till there is a problem. But it did very well. Thank you.
Thank you, man. Thanks for the excellent presentation. I think for past 2 days, with the name of Research Society, I think your presentation is a excellent, what is it, conclusion of this conference.
Thank you, sir.
And with this, could you please, the quiz participants stay back in this hall. Others can please go down to the main hall, the hall A. So there is a presentation here about the nutrition and the lifestyle modification. After that, maybe 15 minutes later. So quiz participants, please stay back here.
Well, it's very, very heartening to see almost the last bit of session in this hall. And it is full, and we ordered some more chairs there. Lifestyle. So this is one of the things which is close to the heart of mine, and which I really wanted to do it. And mind and body happened in the morning, and it was really a good session, which a good feedback. And it was not just an exercise or an yoga session. We evaluate and get back to you. So in continuation with that, we are talking about lifestyle disease. I spoke on diabesity, and just now Dr. Sattur's oration, he told the only options other than lifestyle, there is an option, that is hospitalization. So in continuation with that, I invite everyone for this lifestyle symposium. And since I need to be shuttling, my friends will moderate. We have Pariksha Rao. Must have seen her in the social media quite a lot. She's a nutritionist. I welcome her. And Mala Gurappa, she is there. She's left, okay. And Dr. Samir. Can we play the slides? No, introductory slides. Dr. Samir is a very interesting character. MBBS and then into physical medicines, more into it. Lifestyle is his fore. Dr. S.R. Arvind sir has spoken very high about him, and he said he should be there, and I said, fine, that is one of the things which interests me and definitely interests every one of us. So he is with us, and he's associated with St. John's. And my good old friend, not old by age, but by our association, maybe from class 5, Dr. Prem Kumar is a professor in Kempegowda Institute of Medical Science. And my running partner, and sometimes partners in other crimes too. So I will hand over the session to the team. We will keep it very interactive. We will not run 15 slides into 4 and bore you. A lot of practical aspects will be discussed. It will be a definite eye-opener for even ourselves, even though we think we know everything about diabetes or nutrition. Over to Pariksha. Thank you.
Good afternoon, everyone. Like Dr. Manohar mentioned, we have a wonderful case that we can brainstorm with and understand the role of lifestyle modification. I invite Ms. Vimla to moderate this session.
Thank you, Pariksha. I would like to call upon Shyam Narayan, who's been our patient. He's been newly detected for diabetes, and he started his lifestyle modification and the entire treatment last month in the last week of November.
Mr. Ram Narayan is a very enthusiastic person. We spoke about lifestyle to him. He not only accepted and got his family involved, and he said, I want to spread this awareness. We are very, very thankful to him and his better half. Both can join us, and we can have an interactive session, what went through their mind, and many other questions. I see a lot of senior colleagues of mine being attentive, so I think it will be very exciting.
So we have a 40-year-old male. I'm sorry to put it this way, but he's an engineer. Had a sedentary lifestyle like we all do, given a job profile or a day-to-day work routine. Self-perceived stress levels were at a level of 4 when we asked him that, on a level of 1 to 5, how do you perceive Mother is a diabetic, so there is some predisposition. Stress of diagnosis was definitely there. He sleeps well. Definitely he is observed over a period of time that fluctuating blood sugars leads to a poor sleeping pattern. Medication, he was only on blood pressure medication, and once Dr. Manohar started meeting with our patient here, understood that he's at a borderline of starting with all the complications, and that's where the lifestyle modification was prescribed. Understanding that he's an amazing individual who's taking wonderful control of his health, I just have one question to Dr. Manohar, that what made him motivated enough to put him on a lifestyle medicine?
Lifestyle is coming back as a big thing in our practice. I must say that. We usually write diet, exercise, I always write, but do we really detail on it? Do we have the time? Or do you think the person sitting on the other side of the chair has the interest? Or does he think it is important? So what I do in my practice is, we are associated with a lot of lifestyle coaches, and I keep running, and many people would like to, interested to be joined, we can do it. So first is in our initial conversation, look at the pulse of the individual, how much really he is interested in listening to you. Otherwise, say, I'm being practical. If someone you talk to him and he is not interested, I don't want you to waste your 5 minutes on him, honestly. It's important. See, this is what I have done. This is what some people have done, and reverse the diabetes. If not reverse, they've gone into remission for some time, or they've reduced the medications. If nothing else, their risk of getting into complications, definitely, we have seen in the yesterday's talk also, even you may not get to the goal in every aspect, but your morbidity, mortality comes down. So once you talk to that and you see the response, what I do is I always guide them to our nutritionist and tell, please meet them. There is no additional cost, because some people they spend everywhere else, but for a dietitian, they say, I know everything, I'm 20 years diabetic, you only tell me or give me the paper, I'll read it. They won't even look at it. Maybe they go back, taking a snack and folding that diet chart onto that. So when I met him, he was, see, if you look at him, he is not obese, but he is interested. Because in our short conversation, we made it clear that it will be beneficial not only for people, we were talking about vaccination. There are vaccination at individual diseases, but there is a vaccination for non-communicable disease. That is lifestyle changes. It will not only help your diabetes, but many other things. So he was so inclined, willing, and he has encouraged everyone around him. And thanks to him, he said, I would volunteer and come over here. And he is there since morning, 7:30, attending our sessions, mind-body workshop. Thanks a ton. Over to you. So what did you feel, and what made the difference?
Yeah, basically, a number of times I've gone to Dr. Manohar himself, and number of times he's told me, you're in the borderline, I have to get you into medication next. Your HbA1c levels are high, you have to get into medication unless you make lifestyle changes. He's told this to me about 4 years back as well. But, I personally, like he mentioned it, I would take that saying that, he's telling that, but I think I'm following a good lifestyle, so let me just follow it. I don't think there's a problem in it. But over a period of time, I observed that HbA1c levels are just going up. And this last time that I met Dr. Manohar, that was about a couple of months back, he told me, I think, why don't you get into a lifestyle change? Why don't you look at putting up a continuous glucose monitoring system and then make changes to your lifestyle to see what effect it has and, what happens to you. It looked interesting. It made a lot of sense from what he told. So I said, let me jump into it and let me see what's happening with that. And, it made a lot of, when I started ultimately, they've mentioned that I'm an engineer. So engineers tend to respond to a lot of data. You must have seen that. And it's not only engineers, a lot of people who work around, they respond to data better. We want to see data. So when we take our readings of sugar, say once in a week, or sometimes a couple of times in a day, where you take the morning reading and then the post prenadial. It's only telling you something, and it's really not motivating you to make many changes. But when I put this CGM on and the data came out, there's a lot of realization which came out from that. I mean, my HbA1c levels were high, but I was seeing that my morning levels, that is morning sugar levels were it's okay. It's about 90, 100. I mean, and after meals it was 110, 120. But I observed my evening, that is the night, after dinner, the readings were 200, 220. So I myself understood that, this is what is happening. I think there is I'm doing things wrong. I'm probably not doing it right. Though traditionally I've been taught that this is the way to do it. I have to get up in the morning, do a lot of exercise, and eat well in the morning, reduce the food in the lunch a little bit, and don't eat that much in the night. So I followed that, and I assumed that that was the correct thing which I was doing. But this was an eye-opener. A lot of changes came about in my thinking on, how, things would change. So, based on the health coach advice, I started reducing some amount of the exercise which I did in the morning, introduced that to the night, and the results were, really very nice to see. Those levels of 200, 220, which I was talking about, is now come down to 120. That is in the night, whatever levels were there. So, that's in short, how I got interested in this, and I see a lot of benefits personally on how things are changing for me in terms of diet, in terms of physical exercises, etc.
Thank you so much. So, understanding from a scientific perspective, you mentioned that you split your morning exercise. You were doing 45 minutes of yoga and aerobics, and now you do 30 minutes in the morning and 20 minutes in the evening, and that's making an impact. So, Dr. Prem, my question, or what we can understand here, how basically splitting of that exercise helped, and how post-dinner walk or little bit of exercise helped him achieve a better postprandial sugar response post-dinner?
Well, I can add this way, since as Dr. Mano rightly put, he isn't obese. If you see his physical stature, he seems to be fit enough, and definitely it is never named that he is diabetic. So it is like it follows among everyone. Now, splitting of exercise, splitting up of a physical activity, most of the usual diabetics, what they think is, I do so much of physical activity, isn't that an exercise? So when it comes that way, I run up, I go up and down the stairs. See, that is just a physical activity, but what is that you're doing as a part of exercise? And he, as a regular thing, as he addressed, he does yoga, he does aerobics, and it is session to 45 minutes, etc. Now, how much is he comfortable to do that? Like, is it kind of a stress what he has to do? Like, I have to get up in the morning to do this as an exercise. Now, when you see that way, the comfortability helps in giving you results. And I'm sure that he's comfortable in doing certain set of exercises. Now, can he extend more of it? Is it that only the part of exercises limit him to the yoga and aerobics, or can he add up anything? Or that is what is something what we need to know just about the lifestyle changes. See, as he is following a good diet control and diet practice, now about the exercise and its result basically adds too much to the lifestyle changes. Now, if I have to say about the splitting up into the pattern how he can do in the morning and postprandial, and he's one of the result what he said that it is come down a lot after he does a postprandial walk. That is one of the change what he has split himself, especially saving his time, not just fixing it up for once only in the morning, it is also in the evening. So that definitely gives a result. I think that is one of the reason.
Sure. So I remember you mentioning that now your blood sugars post-dinner have come down to 120. So I think that's a simple modification, Doc, of splitting the exercise without any drug intervention or medication intervention. He was able to get to the level of ideal blood sugar target. Any particular exercise or walk do you recommend?
Yeah, see, now, again, since he was introduced to lifestyle modification, most of the diabetologists, they suggest, okay, other than medications, what can I do? Now, just now Dr. Satur mentioned in his talk, in the end thing, he mentioned what is an alternate to exercise. And he rightly put it as hospitalization. So that is one thought everybody has to get. Exercise has no alternative. It is exercise. Likewise, diet. Now, when I say that, when it relates to the type of exercise he does, it is comfortable for him to do as walking, and most of the time that is what the diabetologist suggests. Do some exercise. What? Walk. Now that is not the end of it. The endurance exercise, definitely it helps. It improves not just for the sugar levels, of course it helps for other cardiovascular issues and also about related to lipid issues, etc. Now one thing what we also note here along with diabetes is stress. Now what are the other ways he can enjoy the exercise? Endurance exercise, definitely strengthening is one. Now most of them think strengthening is not just within the gym what you do. There are so many variations of strengthening exercise programs which has come. There are home-based exercises what you don't have to always use a dumbbell. There are so many things which has come as TheraBands, TheraTubes. So you can go about with that. Swimming is a good form of it. Of course, cycling and outdoor activity, you get relaxed doing that because you have got a different environment altogether. So there are different forms like this. Only thing what you need to know or keep in mind is how much is the extent. Now that is what is to be prescribed to him, like how the drugs are prescribed, likewise diet is prescribed. Now what should be the limit or extent of the exercise he is supposed to do? I think Dr. Samir would be able to add a bit more on that.
Absolutely. So we were reading that you mentioned that your stress levels were around 4, and especially there was a stress of diagnosis as well. So Dr. Samir, can you help understand what's the role of stress?
Hi everybody. First, I'd like to thank Mr. Shyam and his wife, as well as the audience for gracing us with your presence. I'd also like to make a special note with regards to Dr. Manohar and Dr. S.R. Arvind, without whom I wouldn't be here. Coming to the question, first I would like to define stress, and my definition of stress is any unaccustomed stimulus. Now what that means is that we have negative stress and we have positive stress. Now positive stress by the word itself is beneficial for us, and negative stress by the word itself is going to be not very beneficial for us. Now when we talk about diabetes and when we consider stress, and over here we're talking about negative stress, what we need to realize is its effect on the neuroendocrine system, its effect on the sympathetic nervous system, as well as maybe its effect from an immune system. So now when we think about it and we think about how it affects the sympathetic nervous system, we all know the sympathetic nervous system is divided into 2 branches, parasympathetic and the sympathetic part. So an increase in stress is then going to activate the sympathetic system. This activation is then going to cause a downflow and a cascade of cortisol rising, and we know what cortisol can do in the long run, especially when it is chronically raised, right? Now coming to the neuroendocrine system, we consider stress, negative stress, to affect us right from the brain with the release of corticotrophin releasing factors, which then go down and affect adrenocorticotrophin, which then in a sense again instigate cortisol to rise, and this sets this cascade rolling. So in a sense what we're trying to say is that stress, negative stress, can affect us at an organ level, and these organs all combine to create a negative end product. Now what we also need to consider is that somebody who's been told that they have diabetes, somebody who's been told that along with diabetes they probably are hypertensive, are also suffering with dyslipidemia, might be also prone to brain health conditions such as anxiety and depression. And research has told us time and again that in diabetes there is a propensity for one to be depressed. Now if we consider somebody who is first having diabetes, second suffering with a lot of stress, and is now not very comfortable from a brain health perspective, and therefore might be either depressed or very anxious, what will happen is that his compliance with regards to self-care activities, like taking care of himself, being compliant with medications, following lifestyle suggestions, might also plummet. And this will ultimately result in an outcome which is only going to be negative. So I think it's very important for us as doctors to consider that when a patient walks into our chamber, they are already very stressed, and utilize this space to understand what contribution to the disease is via stress, and how we can have a positive discussion to then try and mitigate it.
Thank you. Talking about stress, I'm sure with the word diabetes, first stress comes is what's going to happen to my food, isn't it? That now I'll have all the limitations, I can't eat this and I can't eat that. So this question is for your wife. So how did you manage that when people said that you'll have to change eating patterns or you'll have to cook separately for him? Are you cooking separately for him, or is it a healthy way of eating?
No, because his mom is also basically diabetic, so we three follow the same diet. And it's only for the kids, so that's a little bit different, that's it. So we more or less follow the same diet. So it was not so difficult, but maybe, yeah, of course, introducing salad before every meal, that's an effort because you can't keep repeating the same thing. So there needs to be some different menu. So otherwise, it's all okay. I mean, we are able to take it, it's okay.
Okay. So I think you made quite a bit of changes. You started adding salad before your meal. You started adding some protein like a sambar or something like that. So the moment they moved to a healthy, balanced plate where they reduced carbohydrate by 10%, little bit of rice was reduced and one chapati was reduced, and then protein and fiber was added. One simple change. Whenever I'm asked a question whether there is a diabetic diet, I say no. It's a healthy way of eating, because the word diabetes itself is so negative in its connotation that we think we are not well. Though it is a lifestyle disorder, we can definitely change our lifestyle and modify. And I think it's a very good way that you're looking at it as a very healthy way of eating, rather than saying, I am a diabetic and I'm not going to eat in a certain way. And I think he has a sweet tooth, if I am correct. Yeah. So what all do you enjoy, and how are you managing with your CGM data when you enjoy your sweets?
I mean, previous to this, I have a sweet tooth. I want to eat a sweet every day. And, you know, when I met the doctor and when he told me that you're probably getting diabetic or are diabetic, you know, that was very depressing, like he was saying. I said, the first thought which came to me is, you know, am I going to start losing my sweets? And second, of course, stress levels increases in terms of other thoughts, etc. So now after seeing the CGM data, I realized that there are times at which my levels are low. Now I'm not sure whether, I mean, I'm allowed to do that or no, maybe I have to check with the doctor. But at those times I secretly get into the kitchen and have a bite of the sweet, whatever is there available over there, I have it. And I mean, after doing that, I again looked at the CGM readings, the next set of CGM readings to see whether it had any effect, and I found that everything was okay. You know, it was not bad. It was, you know, it was on level. And, you know, it kind of got me excited, saying that, okay, I mean, I don't have a big disorder now. I can manage this disorder and still get away with whatever I was doing.
Interesting, because that's, I think we all are. It's very difficult to change a habit or a behavior in a day one. And I think the technology today is supporting quite a bit. You could understand how your body is responding to a certain amount of sweet at what time. And what we observed is that why post-dinner his blood sugars probably are not able to go well with the same amount of food. Probably the insulin sensitivity is coming down by evening hours, and most of us have that. Insulin sensitivity is highest in the morning hour, slows down by lunch and delayed by dinner. So mostly we say try and finish your carbohydrates early in the morning, keep dinner high on fiber and protein, so you have a sustained release of sugar throughout the night. Wonderful. I also see you have tried to manage quite a bit of routine to your exercise now. You manage about 26 days of good routine exercise. So I'm going to take this question to Dr. Prem. How do you see with your clients and patients how challenging it is for them to get into this routine of everyday good exercise which is not stressful for them?
As I previously said, once then the doctors suggest the patient do some exercise and the form of exercise. Now, when it comes to form of exercise, there are 3 stages in exercise. That is one thing I should always say, the importance of giving the contemplation, planning an action. What is the type of exercise I'm supposed to do it? Now, once you think, okay, the exercise behavior, now this is what I'm supposed to do. I can't do excess of exercises which can even harm my other systems. It might be the joints, it might be the muscle. The type of exercises could be very less or very more compared to the state I can do. So there is something called as exercise behavior, planning how to do it and sticking on to that, the action stage. Now, whenever we say sticking on to the exercise, there is something called as equipments. Many times I've noticed, now New Year is coming very soon, And most of us make a New Year resolution. The most common resolution is, I will hit to the gym. Now, whether the gym hits you or you hit the gym, definitely you're going to buy a new pair of shoes, new dress, everything, and day one you're there. And maybe the trainer there also so very enthusiastic because he can see a customer walking in. So definitely he will teach you certain stretching and he'll put you on a machine where you have to pump your muscles, so you lift some dumbbells. The third day or the second day itself you develop soreness. So once the soreness develops, you start thinking, okay, now I can't do that much of it. So you limit your participation in the gym. Then other things add up, which we call it as stress. No, it is not stress, it is your planning. Your behavior, what has changed, is not the stress. So once you do not have a proper plan, you're not putting it into action. So once your action is planned or you have a behavior which is set, then maintenance of it. How many times I'm supposed to do? How many days I can do? See, as it is in diet, there are some cheat days. No, in a week, definitely one day is a cheat day where you're allowed to eat anything of your likes. Likewise, exercise also need to rest at least one day so that your muscles can recoup. If there's an injury or if there's something what can reform, there is one cheat day should be allowed to the muscles to do. So likewise, when 26 days is an excellent duration what is kept, or a practice of exercise. Now, form of exercises, it can be the way how the yoga or aerobics or cycling which can be done. Change a form into it. Bring about something new. Add stretching to that. Add some flexibility exercises to it. Try something which is new, like Tai Chi. You get so many online tutorials. Try something new. And also, see, it's not always limited to only the endurance exercise. Strengthening also definitely helps. Focus on which group of muscles you need to build. So that, I think, helps more of us to plan and then succeed in attempting to it. That's it.
Thank you, thank you. And good part is that you don't experience any pains or aches, touch wood, you're healthy that ways. Again, coming back to you, Dr. Prem, that if somebody, like most of the clients that we see, somebody has knee pain, back pain, what would be the best way to get started? Somebody who's just trying to control blood sugar, never exercised before. Yeah. What would be the step-up plan, first plan for them to just get started?
Yeah. See here, just not for the injuries. Even if you have any kind of a problems like a common cold or a cough, immediately next day you're not willing to do an exercise. So that will put you one step back. It's like sticking on to the behavior. That's the very first thing, and how you kind of execute it. Now, whenever there are certain injuries, attend to the injuries. See what has caused injury to you. For example, I just mentioned the gym and the soreness related to the gym. There are two things which can always relate to the pain which can cause. Either the form of exercise what you're doing is wrong, or your muscles or joints are not up to it to take the amount of exercise you're doing. So always plan it in such a way that injury has to be first given a first concern so that you always can continue doing the regular, easy, comfortable pattern of exercise. So it is like guidance is very important. A trainer or if you are self-learned exercise, then you should know how to do it. Then accordingly, you should also have a self-check. We always keep certain goals. Okay, I have to be slim after this many number of days, or I have to reduce weight. So all these things are goals what we keep. And especially when it comes to diabetes, I should say, maintaining the blood glucose levels. Now, as he suggested that he goes with the CGM, and it guides him to have an extra sweet in the night. So likewise, I think it can also help and guide you to do a different form of exercise which can still maintain or balance your blood glucose level. So that's how it can be. And injury-wise, address it in a way, in a form where it should not exceed. If you are feeling it as a discomfort, it need not be the exercise-induced injuries alone. You might have something related to the pattern of your ergonomic changes, which how you sit in an office, or maybe you attempted to lift something which was heavy. So these all can cause some or the other type of musculoskeletal injuries. Now, attentive to it is always with a consultation. Do not self-medicate or do not try something new online. So because there are so many exercises which can relax, which can build up your strength, at the same time maintain your muscle power and muscle strength. So that has to be definitely focused upon.
Thank you so much, Doc. I remember Dr. Manohar when we were talking about how he became an ideal candidate for starting with lifestyle medicine or a lifestyle choice. I understand your role is equally important because it's your body. You have to take care of your health. So what was the initial discussion when Dr. Manohar asked you and you showed your inclination towards it, and how you got started? So he was asking you for 4 years. What was the tipping point that you said, okay, let me do it now?
I think it's clearly, he has been telling this before. And, to be frank, whenever he's told that, and he was mentioning it now, like a New Year resolution, after you meet the doctor also, you make a resolution. And for about 10, 15 days, you do everything that is possible and, try and, make sure that, you're following it. After that, you lose the spirit of it because you start tending to feel, is there any benefit out of this? Is this happening? Am I okay with just taking a pill? I mean, why am I having to do this? So that thought process is coming. But this time it was different because this time Dr. Manohar told the same thing. But then when the CGM patch was put, it was an eye-opener for me to see what is happening within my body. And the moment that came about, I think, everything else fell in place. The motivation came in automatically to me, saying that, I have to change my food habits, I have to change my timings, and I have to probably distribute my exercise from what I was doing before. That motivation came automatically. And if I may, I have to add in over here, I'm at least only at that border level, but my mother her HbA1c levels are at 13.9, which is pretty high. She's still not on insulin because she refuses to take that. But along with me, she's also followed this. She's about 70 years old, but she's also followed this entire thing. And her average blood sugar levels have been dropping drastically. With the same medication which was there, it has been dropping drastically, and I think that's a bigger eye-opener rather than me. And she's following the same thing that I've been doing. She obviously cannot do all the exercises that I'm able to do, but like how he suggested that, whatever they can, she's been doing whatever she can. And, her sugar levels, in the morning, you can imagine, about a month and a half back, her HbA1c levels were 13.9. And now, in the last 1-2 weeks that, we've been measuring her sugar. Now the CGM patch is not there, but the, her fasting sugar is at about 97, 100, post is about 140, 150. So we can ourselves see the change, what is happening. She's not done anything except shift her timings of food. We made it earlier. Otherwise, we used to have our dinner at 9:15 in the night. Now we are having it at 7:30. It's making such a huge difference, and we can feel it as well. Right?
Wonderful. Thank you. Talking about the role that you have to play in making the decisions or taking the right choices at home, my question to Dr. Sameer is, how do you think the mutual goal setting plays such an important role to see more compliance in day-to-day setting?
So one way that I like to think at this is when us doctors leave our hospitals and go to a restaurant or go to, let's say, a store to buy something, we, in a sense, become customers. And over there, we consider ourselves to be the kings, where we think the customer should. Yeah, where we think that the customer should be king. Now, in our hospitals, when we have patients coming in, I think this is a philosophy that we should keep in the back of our mind, where our patient is the king. And they bring to us, yes, health-related issues. They bring to us professional issues which come in the way of their health goals and so many other things. If we were to just look at it from a purely health perspective, and if we were to tell Mr. Shyam that, you know what, you cannot do X, Y, Z, or you need to do X, Y, Z, and that is the way we need to move ahead, then what's probably going to happen is that he is not going to be able to comply with it, and he's going to seek help in other areas, and he then might get it or he may not get it. But if we can sit down with him and if we can consider what can be done, let's talk about it from an exercise perspective. So he has said that he happens to have time in the morning, he happens to have some time in the evening to do a couple of exercises, be it yoga, be it running, be it some other form of body weight related exercises. Then we need to consider how much can he do this and at what intensity can he do this. And then this is a dance where we have to suggest something, he has to agree, and then we have to keep moving ahead. And in a sense, create this feedback loop where we're constantly in touch with each other so that tomorrow, if I have suggested that he needs to engage in, let's say, 15 push-ups, and he can't because physically he's not able to, or because professionally he doesn't have the time, then is there an alternative? That has to be put out onto the table so that the patient as well as us can come to a consensus with what is possible and what isn't. And then maybe we can think about bringing positive health changes into their lives.
Makes sense. So I think we all human beings, we have to be first convinced. And that's the point that I like, that as soon as we understand that a patient is convinced, we should be able to put lifestyle medicine more often. We see it every day on our setup, patients walking, and today I think you all or patients have started demanding. I think lifestyle modification has been the first line therapy for ages, since at least I started studying. I've studied that, all non-communicable diseases, 6 months is a lifestyle modification. I think now the awareness is so beautiful that even our patients are coming back and asking us that, why can't I control with lifestyle? And that's where I think the motivation for all of us has set in, that yes, let's first try with lifestyle modification and make sure that the person is motivated enough to take control of their own health. And maybe that's why we are seeing amazing technology coming and supporting us. I also observed that you mentioned that you stopped taking milk, right? Were you correlating milk and the food sugar elevating your blood sugar post-dinner, or what was your observation?
Yes, I mean, for the first week of having that CGM patch, I observed that, taking the milk was raising the sugar levels up. So when the health coach told me that maybe you can make a change, and she told me to get rid of milk completely in my coffee. Now that's difficult to do, so I bargained with her and made it a 40-60 kind of ratio. But that was for morning coffee. And then night, before going to bed, I used to always have a glass of milk. Today I've had it since probably when I've started having milk. I've always had that. I stopped that. And I always thought that milk is what is keeping me healthy and doing everything for me, etc. But now it's a realization that probably that was the possible culprit. I don't know. They will know better, but possibly that was the culprit, and it's got about changes. I can see from data that it's got about changes. So hopefully that's the answer.
Okay. How many of us think here milk leads to diabetes, milk consumption? Please raise your hands. Anything is fine. Okay, so how many of us would want to go dairy-free to reverse diabetes or control diabetes? Thank you so much. I'm so happy that we don't believe that is true. So when we looked into the data, we did more of food recall. We understood that he's finishing dinner by 9:30 earlier, and bedtime milk is at 10 o'clock. So the glucose load of the dinner was complemented or increased with the lactose load that came with the milk, and that's where the blood sugars rose, right? So sometimes what happens, we just tend to understand that probably there is a culprit, whereas the timing is problem for me. I agree that there is a lot of research today that says that dairy could be one of the possible reasons which is leading to leaky gut and things like that. I am not going to deny that. But when I sit with our patients and I understand whose gut is responsible for triggering diabetes, that lies in gut microbiome. Or when we start understanding a person's response to blood sugar. So when he's wearing a CGMS, I would definitely want to see only milk consumption along with, only protein sources, no carb coming in, and what is his blood sugar response to milk. If I see a dramatic increase in your postprandial sugar, then I'll say, yes, your body is not metabolizing milk. Or on the other side, as a clinical nutrition, when I understand somebody already has an autoimmune disease, maybe gluten sensitivity also, lactose sensitivity, definitely it can trigger. But if these conditions are not there, I do not tell my patients to stop milk. They need to make sure it's antibiotic free, it's coming from an organic farm as much as possible, and it can be only in the form of curd and paneer. You don't like milk, that's absolutely fine, even I hate it. But probiotic form, like a buttermilk or something which is doing good to you, because we Indians, any which way, don't have any probiotic going. And gut health is very, very important for blood sugar regulation. So my observation there will be to split milk and your food, which you already did, and buttermilk at bedtime is a wonderful thing. So now you are having dinner 7:30, and your buttermilk at bedtime, right?
Exactly.
So you're seeing good results with
Absolutely, absolutely. The data shows that it's it's working. So.
that. Right. So I think we all agree here that the way precision nutrition or precision medicine is going, it's going towards personalization, and there is no one rule that's going to fit everybody. Just coming back quickly to Dr. Prem, that if you have to just give 5 tips, Dr. Prem, that what would be a good exercise regimen for anybody who's trying to control their blood sugar and staying healthy.
Now, when we kind of matter is about the control of blood sugar and the type of exercises, always better is with an endurance type. It's like simple yoga, can be cycling, it can also be aerobics, and more importantly, again, sticking out is very important. Now, there are results which has a lot of research which say that the high intensity training in a particular form or with a moderate intensity definitely will help. Now, always we consider as low impact exercises are good to maintain the blood sugar levels. Also, now there is a study which says high intensity training and also strengthening exercise can be added where the patient has to get conditioned to that form of exercise. Now, age matters, the physical stature matters definitely, because these two things. Old patients, yes, we have a different set of exercises with the repetitions or with the practice. At the same time, young patients with their physical stature, if they can do or attain more, why not participate in some more impact type of exercises where they can go for competitions? Definitely there is a chance. Only thing, the form of exercise has to be decided, like how medications are prescribed, likewise exercise also are prescribed. So follow with a better physicians and also with a good consultation with the physiotherapist or a physiatrist who can help with this.
Many thanks. So I think we are closing to the time, and understanding that a holistic approach to managing a person's health is very, very important. Thank you so much. If there are any questions, yes.
Very nice program. Very, very helpful. Just wanted to comment. If we understand that diabetes, hypertension, ischemic heart disease, these are lifestyle diseases, we should understand that we need to address lifestyle, period. That is the most important thing. And the present strategy for management of lifestyle disease is like mopping the floor without addressing the leaking tap. We are developing better and better technologies to mop the floor without addressing the leaking tap. That leaking tap is your lifestyle.
Yes.
And I fully agree with you. There are no separate diets. Sugar is bad for a diabetic, sugar is bad for a non-diabetic. Salt is bad for a hypertensive, salt is bad for a non-hypertensive. It might be worse for them. What is good for me cannot be bad for you, and what is bad for you cannot be good for me. That is not how nature works.
True.
And exercise, he mentioned about stress. Stress, I define it a little differently. Stress is something which you are not able to deal with. If you are able to deal with, there is no stress at all. If you are not able to deal with a situation, with a person, or with your own emotions, that leads to stress. And exercise, yeah, we have created a narrative in our life where it has, we need activities. Actually, exercise should be a natural part of our daily routine. We do not walk, we do not climb steps. Wherever we go, we use motorized vehicles. But if that becomes a part of our daily routine, but we have made it into an activity. And this activity, if we keep using walking, climbing stairs, wherever we are working, the work gets distributed during the day. Many people do 1 hour, 1.5 hours exercise in the morning, and then they sit for 11 hours in front of the computer, which doesn't help. It has to, so people who are working in offices should be told to walk, climb stairs, not to use the lift, and it should be a part of our daily routine.
True,
Thank
sir.
you.
According to your continuous glucose monitoring, when did you measure the sugars after having your milk or your breakfast, what time after your breakfast?
No, I have the CGM patch on.
Yes, CGM, yes. Yes.
So, I mean, I looked at the readings, 2.5 hours after. So I looked at the readings about 2.5 hours after I finished the meal. So I finished the meal at 7:30. I think I was looking at my readings at about 9:30, 10 o'clock. And that was when what was about 200 had dropped to about 120. This is, the changes was I was having my meal at, about 9 o'clock, and I was checking at 11 o'clock, and at that time it was 200. Now when I shifted to 7:30, plus, after 7:30 8 o'clock, I was taking a 20 to 5 minutes walk. And after that, when I checked at 9:30, 9:45, the reading was 120. I mean, this is like consistently over 3-4 days that I saw the change.
Why I'm saying this, I had a similar patient with a similar profile. He too was an engineer by name Mr. Shrikant. His mother was a diabetic, and he used to have this glucometer and was checking his blood sugars. Suddenly one day he decided to have this patch and measure his continuous glucose levels. And one fine day he called me and said, I ate jamun and I had tea, my sugar is 180. He has measured after half an hour after having his jamun and tea. I said, no, that's not the correct way. You should wait for 2 hours to complete the process of insulin secretion and the levels coming to normal, and then you must decide whether to take or not to take. I have a question for you. Does plain milk raise sugar levels?
Sorry?
Plain milk without any additives or nutrients, does it raise sugar levels?
Like any other food, because lactose, galactose both are there as milk sugars. So definitely it has a decent amount of response, in fact. So that's
Does it have a high glycemic index?
No, it has a moderate one, but that's why we just recommend that it is not combined with main meals as well as with fruits. Because the fruit sugar fructose, when combined with lactose, again, we have a very peak response in blood sugar. So we say milk should be as a snack or at bedtime. So we generally try and avoid it. Otherwise, breakfast milk and a complex carbohydrate is a good combination. So quantity of both will matter. But otherwise, it is a moderate one. Milk sugar also increase blood sugar quite a bit.
I have a question. I think probably Samir or Prem can answer this. One of the challenge what we face in the treating the elderly diabetic patients is like most of them complain that they have this osteoarthritis or they are obese, they will not be able to walk. So, I mean, though we have heard and have been telling them to do some non-ambulatory exercise, right? So, any take on that, like, what you would like to tell for the elderly patients?
So to address your question, what I'd like to do is actually cement what Sir had mentioned with regards to us taking care of the tap at first. And if we consider lifestyle as a means to take care of most non-communicable diseases, then we should also consider this, which is my parting thought and a message that I would like you to consider as you leave this place, which is, as children we were told that we should always ask the following questions: why, where, what, when, who. And I think when we come to lifestyle, and if you consider, let's say, exercise, nutrition, stress management, or sleep, similarly, what exercise, where, when, how needs to be considered, because these are prescription strength equivalent. Because today a medicine is known to reduce, let's say, blood sugar by 20%, and so is exercise, so is eating well. So these are prescription strength modifications which we are suggesting. But unfortunately, the broader audience doesn't have that scientific nuance to then state exactly what needs to be done, where it needs to be done. So coming to your question in particular, where you might come across an elderly patient who has, let's say, physical difficulties in engaging in an exercise, primarily bilateral knee osteoarthritis, which is very common. What can be done? The suggestion could be a cycle ergometer, where they utilize their hands. Now, yes, we know that it isn't as good as them walking, because we have larger muscles in the lower body in comparison to the upper body. But we also know that something is always better than nothing.
Yes.
So this is the train of thought that we need to start inculcating in this patient population. And probably if they were to start with, let's say, a cycle ergometer, and then maybe standing for 15 minutes post their meals, or maybe a very relaxed walk while having a conversation with whoever's next to them, we might see their weight then reducing. We might see their pain then reducing. And in a sense, we might then modify their so-called osteoarthritis, and then we might be able to enhance the intensity of the exercise.
I would like to add a few more about it. Since your question was related to the age-related problems as well as chiefly the osteoarthritis and non-ambulatory exercises, definitely see, when we were in school, definitely we all have attended a compulsory class on physical training, the PT exercises. Why don't we do that? It was not, we were not made to run all around. We had to stand according to the beats of the drum or the whistle. We were doing it. That's a good form of exercises to it. And that anybody can do even in sitting or in standing. And more importantly, as we had a beautiful session on yoga in the morning, and yesterday Dr. Hemant also was defining how yoga can manage or help controlling diabetes. So there are so many types of pranayamas which again has a major role in reducing the visceral fat. So there are the different forms of practice where even a non-ambulatory person or a obese person or something related to musculoskeletal and age-related problems can do practice. I suggest that.
This for dietitian. So whenever diabetic come to our clinic, we say them avoid glucose-rich food and eat chapatis and eat biscuits. Okay, how healthy are they? And eat rava foods. So I want to know how healthy are they, whether they lead to leaky gut.
Okay, so if I understand the question, we are saying whether wheat is healthier than rice or biscuits, the healthy claimed biscuits. So I'll take one by one. If somebody is a rice eater, their gut manages rice better. If somebody has been born and brought up eating wheat, they will handle chapatis better. And their body is prepared to handle that glucose response much better. So I have displayed couple of food models when you go and have your lunch. Take a look at the portion sizes there, right? So the chapati size and the rice bowl size, that's where we need to put our attention to rather than just the ingredient. If I have to break down the glycemic index of rice and wheat, definitely wheat is a little lower. But if you're eating 2 big chapati and 1 small bowl of rice, the glycemic index is now same. The amount of carbohydrate that is going in the body is the same, right? Only the gut microbiome or how the blood glucose response will be higher will be different in 2 different individuals, right? So it completely depends on the person's eating pattern. I generally go with what they've been born and brought up eating, their grandma's way of eating, locally procured millets, pulses and everything. That will be the best way. Coming to the healthy labeled biscuits, I don't believe anything is healthy on a processed food. We did want to discuss about that as well. But when you look at the food label, right, I know it has ragi for that matter, but ragi is also processed fine like maida, right? Then how is it ragi? That itself has highest GI, and then we tell our patients that ragi biscuit is healthy. So it's a completely misleading information. We should not fall for these marketing gimmicks, and we should definitely sit down and read the food label. For me, a khakra or a methi, ragi chapati is much better as a snack rather than a biscuit. So just read the food labels. It has high fructose corn syrup, invert sugar. They will hide word sugar, but they will have everything there. So it's our job to inform our patients to make the right choices.
And what about rava, ma'am?
Rava, same thing goes. So it increases your blood sugar the way it will increase, the way poha will increase your sugar. Poha and rava, again, the intestinal transit time is a little different, right? That's where you'll see some difference. Add equal amount of vegetables to either poha or upma, and that is good to go with some protein.
Just read an article in nutrition. So they've labeled all this gluten-rich foods as inflammatory diet.
Okay.
And when they have avoided these foods in diabetics. So the weight loss was more.
Okay.
So when they ordered 2 to 3 kg weight loss had happened.
Okay.
Instead of, they have not modified anything else.
Okay.
So,
Like I
just
said,
had a doubt.
no, so it's a completely personalized response, right? Today, definitely, I am seeing modified gluten that is there on the market. The way we ate wheat and the wheat that we are eating today is completely different. So that modified gluten or gliadin, whatever, is the problem. So we need to understand where our atta or wheat is coming from. If you know the source, it's gone to a fresh chucky and from there you've procured it, I don't see an issue. And there are individuals who are sensitive to thyroid hormone response when they eat gluten. So that could be a response that you are seeing for an individual responding better on weight loss when you cut down on gluten. But it's not a blanket statement. Work closely, understand how an individual is responding.
Thank you.
My pleasure. Sorry, sir? You had something to add on?
Just to add to ma'am what you said is that Mr. Shyam here told us that if the accuracy of the CGM is right, that when he ate sweet, it so seems that his response is not as bad as we'd expect it to be. But maybe that he's not able to metabolize milk as well. So there you have this peak in blood sugar. So as Dr. Sudarshan yesterday mentioned, that today we are reaching a form of medicine which will be personalized. And over here, maybe we need to consider each individual as being different and see what works for them.
So you had a question. Fruits. Okay, so for somebody who's trying to control their blood sugar, we recommend 1 to 2 fruits per day. Healthy individuals must have at least 2 to 3 fruits per day. And this recommendation comes from their phytonutrient intake, sir. We see a lot of antioxidant properties that we consume with the fruits, which is very important for their blood sugar regulation. But fruit has to be consumed as a snack, should not be as a part of breakfast, lunch and dinner. Like here we have a habit that meal will finish, we'll end up with finishing with a small banana, which is good, which actually calms down stomach acid wonderfully, but not for a person who's trying to regulate blood sugar. So for them, fruit has to be a snack, 2 hours after food. That's what I see success with. Anything is fine. 2 hours gap has to be there between fructose and your glucose coming from your meals. For a diabetic, I don't recommend that. I do not recommend that, but if the goal is for weight loss and a way to control or give some rest to their gut, maybe yes. Again, very, very individualized. Somebody who's dealing with thyroid issues or some kind of inflammatory process that's going in the body, I don't recommend. And it is never one fruit. So we never feel satisfied with one apple, right? It'll be a bowl of fruit where 5 fruits have gone in. That fructose load is so bad for our liver that the whole purpose is denied. Yeah.
It was very contrasting that we prescribe exercises for all our patients. But also look at these things. Every day when he goes to the gym and come back, his blood sugar used to shoot up. And Sunday, when he doesn't go to the gym, blood sugars are normal. The point I would like to make here is, some of the exercises are not suitable for everyone. When we are prescribing exercises, we need to be very, very careful because any exercise which is not suitable will add to stress and stress will increase the blood sugars. I hope
that's a nice point what you mentioned. I just mentioned that planning of an exercise itself is a stress.
Yeah.
So pushing yourself to do something more, definitely the double stress. So I think that would be the thing what you notice in the patient.
Always please consult the sports medicine specialist when you are putting a patient on special activities. Yeah, thank you.
Thank you.
Here I'll just like to add to what you've said, and over here what we need to realize is that when we exercise, we are actually creating stress which is negative to the body, because that is not our body isn't very happy when we exercise. Muscle grows courtesy the micro tears that we see and similar, but what we are looking for is the following adaptation that exercise will bring in. And over the course of time, if one were to stick to exercise, agreed, a routine which is within their limits, the adaptations far outweigh the negatives that come with that momentary rise in blood sugar or the momentary rise in, let's say, a pain that one might have to tolerate after doing exercise. But as you mentioned, I think it's very important that when a diabetic comes into our clinic, we need to consider that they may have other comorbidities, and a one-size-fits-all prescription may not work for them. So you have to be careful with what you suggest, why you suggest it, and maybe request them to undergo certain investigations so that they are safe to engage in these exercises.
I see many clients like that, many patients, and when we sit down and do a food recall with them, they are going on an empty stomach to the gym, right? Their glucose levels are completely empty, their tank is empty, and that's where the muscle glycogen or gluconeogenesis sets in place. Only thing that we observe does wonder is that giving them a protein breakfast or protein snack before they hit the gym. And that's where the glyconeogenesis part comes down. Your alpha cell dysfunction, which is producing so much sugar as a response to exercise, reduces, and they enjoy a wonderful exercise session. So pre-workout snacking and post-workout snacking shows me some wonderful results, especially with people who are not able to handle the stress of exercise in the gym for their blood sugar control. That's nice. Absolutely.
Yes.
Yeah, I think it was a wonderful session. Yeah.
So definitely I agree with it, but how much, right? So handful is what we need because they are high in saturated fat as well. MUFA as well, PUFA as well, they're good, but the quantity has to be controlled. And somebody who's dealing with IBS, IBD or gut issues should go very easy on dry fruits and seeds and oil seeds as well. So one handful generally are good. Somebody should keep an eye on their bowel movement. If that is getting disrupted, that means body is not handling it well. My pleasure.
I think one last question. Yep.
So, sorry, sir? Soya bean. Yes, definitely it's good, but the real soya bean, the extruded products that we get in the market, it is processed so many times, the ultra processing leaves protein quality to be 0. So the bioavailability of that protein in our body is 50% only. Where I say soya has a PDCAS of 1, that means it's as good as egg. Processed soya, the chunks or the extruded products that you see today in the market, that will hardly have 50% of the protein left in it. So absolutely, it's a good choice. Pleasure.
I just wanted to ask you, what's your take on intermittent fasting as far as diabetes is concerned? Or
No, I think we'll take this question and we can end the session of this.
So again, depends on the goal of the individual, right? If the person has controlled blood sugar or it's not a brittle diabetes, I definitely go for it. But I start very slow. So I start with 12-10. 14-10, and then move it to 16-8. So once your client's body has adapted to understanding when the food is coming in the body and when not, and when your liver is working and when your pancreas are working, once that balance is settled, I see wonders, frankly, but not with a brittle diabetes. Because we are born and brought up in such a way that our ancestors or grandparents started eating at 5 in the morning, stopped eating at 5. So we have a cycle to get into intermittent fasting, but again, very, very individualized. Some people have a hangry response. They don't handle the fasting period very well. If cortisol is coming into picture and increasing blood sugar, I do not recommend it. So personalize it, but I see good results on intermittent fasting.
Okay, I think can. So I'd like to thank, first of all, both of you for volunteering. So as I see, the success of any talk depends on how many questions that comes out. So I think if I allow, I think it can go for another few more minutes or even an hour probably. So it was a well covered topics basically on the diet, exercise, stress, every aspect of the diabetes lifestyle modifications, everything was covered. So as we all as a practitioners of diabetes, like we always say to the patients that you have to follow diet and you have to exercise. And as Dr. Pariksha, Dr. Samir, Dr. Prem has told that this particular topics which we are able to tell to our patients in a structured way, I think definitely it's going to have a long-term effect in terms of keeping their blood glucose levels. If a person is in a pre-diabetic stage, there is definitely a possibility of reversing it to the euglycemic stage as well. So I think it was really a wonderful session. I would like to thank Dr. Pariksha, Dr. Samir, and Dr. Prem for his, their talk. So I'd like to have a group photo.
I still feel diet takes over exercise.
I request everyone to stay back. There is after this there will be a Nadagoda lecture. It's going to last for just 2 minutes. My request to please have your seats. I think we are coming to the end of the session, so I'd like to have a symposium slide of Vinaya Nadagoda Honor Lecture. Dr. Nadagoda is a famous leading physician, diabetologist, and an entrepreneur and a philanthropist from Hubli and North Karnataka. To encourage young diabetologists and researchers, Dr. Nadagoda has contributed generously to KRSSDI and many other organizations to institute orations. To salute and evaluate the virtues of this family, Mrs. Vinaya and Dr. Nadagoda Honor Lecture has been instituted. Thank you. I think we have come to the end of this session. So thanks everyone. Please join for the lunch.
Before you hit the skip button, I can get your car insurance quote in just 2 clicks. Tata AIG car insurance. Trusted now. Fantastic now.
कहाँ से हैं आप?
इलाहाबाद से।
क्या नाम बताया था?
अलग अलग पांडे। अवार्ड अवार्ड का तो पता नहीं है, पर सबसे अच्छा टीचर बनना है।
पे 12 क्यों बजे?
12 बज गए। नो विश, मेरा बर्थडे भूल गई।
11:59 ही हुआ है।
खास मिडनाइट डिलीवरी सिर्फ FNP पर, खास रिश्तों के लिए। डाउनलोड FNP नाउ।
आ गया है नया लिम्का स्पोर्ट्स, ग्लूकोज और इलेक्ट्रोलाइट्स जो दे फास्टर रिहाइड्रेशन ताकि आप रुके नहीं।